Go ahead.
All right, can you all see me? Good morning. Oops, wait, I need to go back. Good morning. I'm going to start over. And welcome to everyone to our 10th annual Gynecologic Cancer Symposium. I'm Lee Mae Chen. I'm the Division Director at UCSF G1 Oncology. I'm at the Helen Diller Family Comprehensive Cancer Center. And September is Gynecologic Cancer Awareness Month. We've had the privilege of hosting a patient care symposium for the past decade. And as you all know, for those who are frequent attenders, we have gone to a virtual platform a couple of years ago. And as we developed this virtual platform, we thought that it would certainly be appropriate to expand to people in other parts of the state, other parts of the country, and then collaborate. So this year, we're really pleased to be able to collaborate with some of our sister UC institutions. And you'll see with our program that we really hope to broaden our horizons, both for our patients, but all the G1 oncology patients in the state of California and beyond. In terms of our sponsorship, I really wanted to thank our sponsors. Both GSK and Myriad have given to this program for us today. Oops. And I also wanted to thank our friend circle and thank our colleagues at UCLA Health. We really have had great collaboration with them from a symptom management program standpoint, and you'll see from their physician assistant team presenting to us today in terms of thinking about caregiving. We really wanted to acknowledge them as well. Our friend circle is our immediate partnership here at UCSF, and this is a patient-led circle of friends of our patients, advocates, their family members. And they have been bringing together our group. They help to support the content for our symposium and really give us interaction for what we want to learn from each other and what we want to learn about. And that helps us to be able to develop the program for our symposium. They're also always looking for new people to join, and their current gatherings are also by Zoom. And they do have some lunchtime gatherings if you're in the Bay Area. But otherwise, you'll see on these slides going through the contact information for the friend circle. So if you're interested, please get in touch. Today, as I mentioned, is a special day because we have some great speakers from both UCSF as well as UC San Diego, as well as from the Charcot program, as well as from UCLA. So stay tuned for some of these highlights. The first part of the program will be Dr. Fu and Dr. McHale. We'll have a little break. Then we're going to have some review of some resources that I think will be important for our patients to see. And then finally, we're going to have some sections on caregiving, surviving, and thriving before we go out to our breakout sessions. This part of the program is a webinar. And so if you have questions, please put them into the chat. And we'll be watching the chat to be able to take Q&A. If we cannot answer the questions during the time that we have allotted, because we do have a lot on the schedule, we are going to have discussants. Most of these speakers will be in the discussion section at the breakout sessions to take additional questions later on. And the breakout sessions are Zoom rooms where we can have conversations one-on-one. The breakout sessions are at noon, 12:15. And in addition to the email that Kevin sent out yesterday, you should be getting an email today that reviews an additional breakout session that we added for a video that we were able to get from Dr. Jocelyn Chapman. So what you'll see is many of our speakers are going to be in these breakout sessions. We also have a session on looking at pathology reports. We have a session that is talking about the clinical trials program. Dr. Alvarez has made a video for this, and our research coordinators will also be online to talk about navigating clinical trials. So Kevin, I'm going to have you go to the first slide of our session here, and we'll get started. The theme for this year's meeting is a journey of the patients, and basically what we the theme of our our symposium today is the journey for the patient, and what we want to be able to give you are some tools for your cancer journey. So I'm going to stop sharing and we will go to our first slide, Kevin. Thank you. So we wanted to present to you the J.J. Zhang Memorial Lecture. Ms. Zhang was a beloved patient, wife, mother, sibling, friend of the GYN cancer program. And as she fought a difficult battle with cancer with courage and resilience, after her passing, her family wanted to recognize her. And we have implemented this memorial lectureship in her honor. Next slide, please. This year, I have the pleasure of introducing Dr. Catherine Fu as our J.J. Zhang Memorial Lecturer. And Dr. Fu is an associate professor who, after a decade, has rejoined our Division of Gynecologic Oncology here at UCSF. She was a resident at Stanford, did her fellowship at UCSF and Stanford together with us, and then completed her PhD at Stanford before going to Washington University in St. Louis. She is a nationally recognized and well-funded researcher in basic science. She's the director of basic science and translational science for our GYN Oncology division, and also holds the John A. Kerner Chair in Gynecologic Oncology. She's going to be speaking us today on new therapies in uterine and ovarian cancer. Thank you, Catherine.
Great, thank you so much. Let me load my slide. And I just wanted to say thank you very much for this opportunity, and really for everyone who's on this webinar, and in terms of spending your mornings with us. I really hope to spend the next 30 minutes giving sort of a quick snapshot. I mean, the title of the lecture, although really exciting, can really be a whole day, a whole week's worth of discussions and information. So what I try to do today was really distill it down to the main questions, particularly for patients and consumers, in terms of, when we talk about novel therapies, how do we think about them? And so what makes a therapy novel? And so I try to think about it in terms of, is it a new class of drug? Is it the delivery system? Is it maybe a biomarker for better selection for this drug? Is that what, is that how we define novel therapies? And so throughout this 30 minutes, I really want to focus on those types of ways to approach this question. And of course, we always think about efficacy. How effective is this treatment? Is it really going to have any response for my cancer, my tumor? And what about the side effects? We really need to really think about nowadays, not just how is it going to maybe take away and improve the disease, but also what are the side effects that actually might continue to have and might not be reversible after the treatment? And then really thinking about prior treatments and other residual side effects. How can we actually utilize that information to then guide us for the next treatment? If it's something where someone is having, sort of residual fatigue, if we talk about another medication that might be novel, but actually we know really makes the fatigue even worse, let's talk about that with your provider and figure out whether or not this novel therapy may be really the right decision in your pathway and in the journey. And so today I'll focus on ovarian cancer and endometrial cancer. And one piece to highlight when we think about ovarian cancer, we say that term, but it's a very broad term. And so I'm trying to, during this talk, really highlight some of the biology and the novel therapies that are perhaps specific to high-grade serous or specific to low-grade serous, and some of the clinical trials actually that are here at UCSF to help guide these treatment options. And then when we talk about endometrial cancer, that again is a very broad general term. And so whether or not the question is, is this trial for any endometrial cancer in terms of recurrent, or is it specific for particular kinds, such as uterine serous cancer? And I'll highlight some of that biology and data as well. So this is taken from a recent review, actually, from the American Society of Clinical Oncology, ASCO 2022. And this is on ovarian cancer. And it's, the group's way of distilling, what in their minds are novel therapies. And I thought this was a really great place to start when really figuring out and trying to explain what are the novel therapies in ovarian cancer currently that we think about nationally and internationally. So ways to think about it is, are we targeting the tumor microenvironment? And what does that even mean? So the tumor microenvironment means, where does the tumor sit? What are its neighborhoods? We talk about the omentum, we talk about the peritoneum. That is, in a way, the tumor microenvironment. And so are there ways to actually attack this and focus on the microenvironment? And I'll share some data with you on that. And then what about improving drug delivery systems? Some of you may have heard about this antibody drug conjugate or nanoparticle directed systems. And so I'll also have a slide kind of highlighting what that actually means within ovarian cancer or GYN cancers as well too. And what about PARP inhibitors? I think many of us have heard about PARP inhibitors. And truly, when we think about PARP inhibitors, we talk about, is it really targeting those with BRCA mutations or homologous recombination deficiency, genomic instability? And I'll have a slide talking about that. But we also have seen that for those who've had PARP inhibitors, that there could be resistance, or maybe for some, they're actually resistant from the outset. So how can we actually improve this therapy that we know can actually be really amazing for others? And how can we actually make that and sort of change the biology so that many more can respond to PARP inhibitors if they're perhaps resistant, even for the beginning of the disease course or maybe after having received PARP inhibitors? And then how do you enhance PARP inhibitor activity? Can we combine it with immunotherapy? Can combine it with anti-angiogenic like bevacizumab? There's some trials about this work right now. And so all four of these are ways that are, really research is ongoing. We have some research that have already happened with clinical trials, but then there's, so many research and scientists that are actually working on these specific questions as well as others right now. So I'll really just take one slide each, or one to a few slides each to really sort of highlight and summarize this here. So let's start with PARP inhibitors. And PARP inhibitors, I think of most of the novel therapies have really changed our landscape. And I won't have time to go into all of how it changed everything, but in general, for those who have BRCA mutations, alterations in the tumor, in germline, we see that they can be effective, but they also can incur resistance. So how exactly do PARP inhibitors work? I think that would be a way to kind of set the foundation to then understand how resistance can occur. And so the figure on you're in the middle, I guess, right here, that hopefully you can see my pointer, shows how a normal cell that, let's say, has a BRCA1 or 2 gene and protein that's intact. So what happens is when a PARP inhibitor comes in, it sort of attacks the tumor or the normal cell or tumor cell, let's say, and it doesn't allow these single strand breaks to be repaired. And so then there becomes additional breaks, such as double strand DNA breaks. However, with the intact active BRCA1 or 2 protein, the cell can repair themselves. And so the cell survives. So this happens, let's say, in tumor cells, for example. However, if there's a tumor cell that has a BRCA1 or 2 mutation or deficiency, we call it, this single strand break that then, again, is not able to be repaired because of the PARP inhibitor, then becomes a double strand DNA break. And then because the BRCA1 or 2 protein is not there, not active, then this actually causes DNA damage and then cell death. And so this is the terms, we sometimes use these terms called synthetic lethality, where we're taking the biology of a tumor cell and we're actually using it against themselves and actually applying this new therapy to actually allow it to, lead to cell death. However, we know that tumor cells are, sometimes can alter themselves and become resistant. And so this figure here, when you talk about targeting PARP inhibitor resistance, you can see all the different ways that groups are working at how to actually target this PARP inhibitor resistance. These are all the different ways that the tumor cell can perhaps be altered, and just really highlighting that these are the different ways to approach this. And then thinking about enhancing PARP inhibitor activity with immunotherapy, when we think about the combination, we also think about, sort of the side effects and what actually can happen too. So this is something that, as a clinician and as a researcher, we're really mindful of together to make sure that when we're combining it, the biology makes sense, but also really being aware of like how it actually manifests in, someone who's actually taking the targeted therapies. And then this here, when I have this HRD and HR non-HRD, it really just helps to highlight the idea that although I'm talking about BRCA1 and 2 mutations, there's a whole family of DNA repair proteins that actually can be altered that can lead to what we call homologous recombination deficiency that may still actually be improved response to PARP inhibitors, and perhaps benefit from targeting PARP inhibitor resistance. So again, I can talk many hours on this, but I think just in terms of the timing to move on. So in terms of the drug delivery system, how can we perhaps improve upon that? So some of you may have heard about antibody drug conjugates, and what does this actually mean? So I have a picture from the review here that highlights, sort of this payload and the target. And so to really distill it down, what is antibody drug conjugate? It's a way to deliver a drug. And how does it do it? So the key is actually this, the target. What is the target to an antibody drug conjugate? And what does that mean? So the target, it happens to be, perhaps think about it like a signaling protein. So I like to think about cancer cells where they have a certain language and they actually have signals that they like to express and talk about to themselves that helps encourage other tumor cells to come and become active. And so what antibody drug conjugates can do is that they take this neural pathway, they target it, so they focus. So we know, for example, cancer cells highly express, here, for example, on the table, folate receptor alpha or tissue factor, NaPi2b or HER2. So this antibody drug conjugate actually uses that as a target. And then it has what we call a payload or a toxin. And that's what the payload is here, where it's an actual, almost like a chemotherapy that then can go into the tumor cell and then lead to cell death. And the antibody drug conjugate is, currently also thought about in terms of, what are the side effects? Some of them are like very specific and different than what we're used to with chemotherapy. Some are also similar. So these are all the thoughts behind, kind of developing novel therapies and how to understand if this may be, therapy that could be useful for you. And so as a context, though, the antibody drug conjugates are currently not FDA approved. So these are all under clinical trial. Some of the clinical trials have resulted. I don't have time to go into all the results, but in general, there are some that look very promising for our field and for the treatment for GYN cancers. So in terms of targeting the microenvironment, this was another piece here. And here we're going to highlight AXL-GAS6 pathway. And one of the reasons I have to say is that I did work on this pathway back almost 10 years ago as a graduate student. And back in the day, we were really trying to understand what are these signals that the tumor cells can actually express. And one of them that we identified was AXL. And, when we think about, okay, well, a tumor cell expresses a signal, then what? Well, we want to understand, does it really affect survival? If tumors have high expressing AXL, what does that mean for survival? And we did identify that high AXL did correlate with poor survival, you can see here. So this is a typical, what we call Kaplan-Meier curve. When we look at and compare tumors that have low AXL staining versus high AXL staining, and then we ask, what does it do to the progression-free survival or the overall survival? And so you can see that in women that have advanced stage ovarian cancer, for those that have low AXL staining, they actually have much longer overall survival than those have high AXL staining. So that made us think, well, what if we can target AXL? What if we can actually inhibit it? What does it do to the tumor cell? Would that actually cause the tumor cells to perhaps not be able to grow anymore? And we found that indeed that was the case. So when we actually look at these, and this is just a snapshot of the data, 2 different ovarian cancer cell lines, one grown from the ascites of a woman who signed consent to allow us to grow her tumor cells. And we actually treated these tumor cells in a dish and looked at treating with paclitaxel, a very common chemotherapy, versus the AXL inhibitor versus the combination. And you can see that each of these dark dots here represents a tumor cell colony. When we actually do the combination of the two, you can see these cell colonies are pretty much non-existent. And we are able to see this in at least 2 different ovarian cancer cell lines. And then this has led to a clinical trial, which I'll show you in the next slides. But I also wanted to highlight during this time too, an emerging data that we actually have recently published, and hopefully we'll be able to move to a clinical trial, hopefully someday, is the idea of a PARP inhibitor, olaparib, for example. So the same concept, we take ovarian cancer cells, place them on a dish, and treat them with a PARP inhibitor or the AXL inhibitor or the combination. And you can see the same thing, that when you look at the combination, there's definitely less tumor cells growing than when you actually treat with olaparib alone or AXL inhibitor alone, suggesting that perhaps this combination as well can maybe improve the sensitivity to PARP inhibitor. But I'll go back to the AXL inhibitor and the paclitaxel as well, because this is what has really developed into clinical trials. And so this led to a phase 1b clinical trial. So the phase 1 trials, what that really highlights is we're looking at safety and toxicity. And as a secondary outcome, we can look at efficacy, but truly these phase 1s are small studies that are looking at how safe is it and what are the side effects, and are any patients not able to tolerate this treatment combination. And so this was in a platinum-resistant setting, and providers and patients are able to decide if they wanted to have paclitaxel in combination with AXL inhibitor or pegylated doxorubicin. And then again, the safety was the main focus. And so in general, patients tolerated this very well. The main side effects were those that we would see with paclitaxel or pegylated doxorubicin. And this resulted in a publication that you see here. And so part of the secondary objectives, we always want to know, okay, we know it's safe, but is it effective? And so to do that, we look at parameters called complete response, partial response, or objective response rate. And this is based on the CT scans that we have during the clinical trials. And so we can see that with the combination paclitaxel, there were actually 2 women who had a complete response. And then there were 5 that had partial response, and we add together, the objective response rate was about 36.8%, which in terms of platinum-resistant ovarian cancer is one that is hopeful. And when we look at actually drilling down and saying, well, we know that some women receive bevacizumab, how does that affect maybe the response rate? And so this is very exploratory, and exploratory meaning that, this is not definitive, and this is just something we're trying to kind of understand if we can maybe improve responses based on, looking at different criteria. So very exploratory. So when we look at women who have no prior bevacizumab, and we look at this versus women who've had prior bevacizumab, we can see a pretty dramatic difference in response rate. So for women who have not had bevacizumab, the objective response rate was about 66.7% compared to 10%. And then this has led to the question of, well, can we in the phase 3 trial, when we're comparing standard of care to this combination, can we maybe actually focus on a cohort or a group of women who haven't had prior bevacizumab and see if indeed this is true, if truly maybe this can actually enhance the response of this combination. And we also looked at other markers that might actually be able to correlate with the response. So one of the pieces I mentioned early on with novel therapies is, is the novelty of the therapy that there's a biomarker or something that can actually help predict or associate that there's going to be a response. Because right now it's been difficult for us to say, gosh, I can tell you, with 100%, certainty that you'll respond to this treatment. It's really difficult for us to do that. And so we're part of the research and part of the clinical trials, and the novelty is to say, can we do this actually? Can we figure this out? And so this was actually an attempt to do just that. So the blood of the women were taken during the clinical trial before one of the cycles. And then the blood was taken and actually analyzed for what we call soluble AXL and Gas6. So these are some of the molecules that are floating in the blood. And we identified that actually if there's a certain ratio of 0.773, the women were actually all responders if they had that ratio during that certain period of time. And so this is also going to be pursued for the phase 3 trial too, in terms of women having their blood drawn and measuring this ratio to perhaps hopefully confirm that this is indeed a way to optimize if we can figure out who would respond to this treatment. And so this has led to the phase 3 clinical trial that's actually open at UCSF and other places and institutions internationally, as well as nationally. And currently the cohort is really looking at the bevacizumab naive. So the ones that have had bevacizumab, that cohort has already been enrolled. And so we're really just focusing on the bevacizumab naive. There's about 60 more patients that are needed for the trial to really be able to then start answering the questions and trying to see whether or not this could be another treatment option. So with that, I'm going to now switch over to low-grade serous ovarian cancer. And I hope in the high-grade serous ovarian cancer segment, we were able to really understand what novel therapies are in terms of delivery system, in terms of new different pathways, in terms of how to maybe think about improving resistance and how to actually go from the laboratory research findings to a phase 3 trial. So now what about low-grade serous ovarian cancer? I don't really have time to kind of talk about all the nuances about this, but hopefully in the other sessions we can address it. But in general, we think about this type, we want to use the biology. So we know that low-grade serous ovarian cancer is different than high-grade serous in terms of its biology. And how can we utilize this biology to create and develop novel therapies? You know, currently back when I was training low-grade serous ovarian cancer, we gave chemotherapy. And, you know, although that is still an option, we want to really start thinking about other ways to treat it based again by the biology. So one way to address this is to look and see, well, you know, what else do these low-grade serous cancers express? You know, this whole signal, like what kind of language are they speaking? And so we see that actually low-grade serous cancers also have expressed and have CDK4. This is a checkpoint part of the pathway. But I think the big picture piece is that CDK4 has been shown to drive resistance to endocrine therapy. What does endocrine therapy mean? It means endocrine is an inhibitor to the estrogen and progesterone pathway. And so thinking about it this way, the question is, can one of the novel therapies be, can we inhibit CDK4/6? And that would actually enhance the response to endocrine therapy. And interestingly, this concept has been thought about from breast cancer. And so this is a paper that was recently published in March 2022 that asked this question of advanced stage breast cancer. And this is what it's typical, again, Kaplan-Meier curve. And in this case, both groups had letrozole, which is in endocrine therapy. And what they asked was for women who actually had ribociclib, which is a CDK4/6 inhibitor, with letrozole, do they actually do better in terms of survival? And indeed, you do find that they do. So there is 63.9 months for ribociclib with letrozole compared to placebo with letrozole alone. And this has led to the development of GOG 3026, which is a phase 2. So phase 2s are for efficacy because it's already passed the phase 1, which we know is for safety. So for the phase 2, it's looking for women who have recurrent low-grade serous ovarian cancer and the opportunity then to receive letrozole and ribociclib together. And that starts to highlight this trial is open at UCSF for enrollment as well. And so this really gives an opportunity for novel therapies, novel ways to use the biology of the tumor almost against itself, almost, how can we actually better target these tumor cells using the biology? So next we're going to go to endometrial cancer. And this slide highlights that endometrial cancer can be molecularly thought of in terms of pathology, like under the microscope, as well as sequencing. And it's a complicated slide, and it's really just to kind of highlight that we're trying to think again about the biology of the tumor and how to utilize this for treatment options, such as chemotherapy and radiation, or perhaps more observation and close surveillance. And this slide looks at sort of the other novel therapies, what are the signals that these endometrial cancer cells express? And so here I've highlighted, it's a very busy slide, which actually is encouraging me that we're really trying to really understand endometrial cancers and how to actually develop personalized ways to address this. So in the purple here are highlighted new therapies. And these new therapies are actually in a clinical trial that I'll show in the next slide that's open at UCSF. And this really highlights the way that we're targeting endometrial cancer at the different ways in different parts of its disease progression. And so here is AFT50 Endomap. And these here, you can see these are the study drugs here. And this is one that's actually designed for biomarkers as well as novel therapies. So really suggesting that for tumors that are biomarker negative, they would then receive an anti-androgenic plus immunotherapy. For those that have a PI3 kinase AKT signature, then they receive an AKT inhibitor with immunotherapy. And those that have a genomic loss of heterozygosity, receive a PARP inhibitor plus immunotherapy. And so this is a trial, again, that is open at UCSF. And the last few slides, I really wanted to kind of highlight what are the novel ideas, because these are really, not standard of care right now, but just how we're thinking about the field. So one way is I mentioned, how can we predict who can respond? So this is a trial that we opened up at Washington University, in which we asked the question for those who received immunotherapy and endometrial cancer, can we predict who would respond better? And so we're able to collect blood before and after pembrolizumab, and then performed a CyTOF, the single cell analysis of the immune cells, and to ask, are there patients that actually have different immune cells when they actually respond versus don't respond? And so here you can see just one quick slide that for patient 5, who was a non-responder, they actually had different trajectories of their immune cells. So for those who responded 6, 8, and 10, you can see these immune cells actually went up after the immunotherapy, and they actually were responders, highlighting, suggesting that maybe we can start to predict, who would respond to this immunotherapy earlier on, rather than, sort of giving immunotherapy and hoping that it actually will be a response. And then lastly, we'll talk about one slide, cell engineering, and what does this all mean? So there's in other fields, such as leukemia and lymphoma, you can see down to your right, the FDA-approved CAR T-cell therapies. And ovarian, endometrial, cervix, this has been ongoing. And really the question is, how can we use and utilize the immune cells from our own bodies to be able to attack and fight the cancer? And one way I want to highlight is the CAR protein. So one thing that we are actively doing here is really trying to identify what are the actual proteins that are specific to GYN cancer, specific to ovarian and endometrial cancers and cervix cancers, and then utilize the development of this to be able to then benefit our patients. And so this is a schematic of, sort of the whole process of it. And UCSF has been, committed to this in terms of the Living Therapeutics Initiative that's here at Mission Bay. And so this is more just a, hopefully in the next few years when we have this symposium, we can, certainly share some more updated results on that. So just wanted to end to acknowledge, of course, the people in the lab that actually did the work and performed the work. Special thank you to Maggie Mullen, who is currently at WashU and had worked on the AXL and the ELAPRA project and currently has a lab there. And then, of course, my clinical colleagues, and Stephanie Cham and I are the newbies. So we still need to have our pictures here too, but just wanted to highlight that. And thank you again for your time.
Thank you so much, Dr. Fu. We have time for one question that was put into the chat earlier. And I think that you talked about it a little bit, but for the audience specifically, why are PARP inhibitors not recommended for endometrial cancer? Because we're talking about all these different targets, and PARP inhibitors sound great. Why not for endometrial?
Yes, so I would say that stay tuned, because that is definitely a way that we are actually thinking about and looking at endometrial cancer. And part of it is actually more let's say biomarker driven. So for those that have a BRCA 1 or 2 alteration, that could be a possibility. It's just not as common in endometrial cancer. That's one of the main reasons. And then really we're then thinking about it broadly, like not just the BRCA genes, but what about the homologous recombination repair family? And so that's the one I mentioned before about thinking about homologous recombination deficiency, and maybe that those tumors would be more accessible to PARP inhibitors. So I would say that's actually where the field is going.
Great. We'll continue to watch the space. Thank you very much, Dr. Fu.
Thank you.
One of the joys about hosting a symposium is that we get to invite our friends to participate. And I have the pleasure of introducing Dr. Michael McHale. Dr. McHale is the professor and division chief at the University of California, San Diego. And Dr. McHale was a resident at the U.S. Naval Medical Center. He did his fellowship at UCI when I was a fellow at UCLA. And afterwards, he served our country in the Navy and is currently at UCSD for the past decade or so, huh, Mike? He has developed a program at UCSD looking at hyperthermic intraperitoneal chemotherapy, or HIPEC, for ovarian cancer. We're just in the phase of starting this program here at UCSF, and I wanted to invite Dr. McHale to speak on their program. Thank you, Mike.
Thanks, Lee May. Thanks for inviting me. I'm just going to pull up my slides here. And first and foremost, I want to thank you all for inviting me, and I just want to compliment you on an incredible symposium. I was talking to Lee May prior to the start, and I'm hoping that we can invite some of our patients in the Southern California area to join you all next year, because it just seems to be an incredible event. So hopefully we'll have more San Diego representation for your 11th annual symposium. I also want to say, hey, I tell you that I'm sorry if my 4-year-old decides she's going to photobomb the Zoom. Wednesday night, we had this presentation to the chancellor and the CEO and the dean, and she thought it would be funny to join my presentation. So after we had this long conversation about why it wasn't a good idea, afterwards, she concluded her statement saying, well, Dad, I think I added some fun to the presentation. So I'm hoping she doesn't try to add fun to our presentation, but if she does, I want to apologize in advance. So what I was asked to address today is really kind of parallel to what Dr. Fu just presented to you over the last 30 minutes. We are at such an exciting time with respect to what we're doing with for women with gynecologic cancer, specifically for ovary, as well as endometrial, as you heard a lot about, but also for cervical cancer. And it's really a real exciting time to be a gynecologic oncologist. It's exciting to partner with our patients and to ask them to participate in some of the clinical trials that are really leading to some of the more novel advances that we've observed over the last 5 years or so. And there's more to come. But in parallel to the novel therapeutics, there has been some movement with respect to, can we do anything differently at the time of surgery? After we subject a patient to a long cytoreductive effort where we try to remove all the tumor for those patients with advanced ovarian cancer, is there anything else that we can do that may actually, in fact, improve outcomes? And that's what I'm going to talk about, the role of hyperthermic intraperitoneal chemotherapy at the time of primary surgery for ovarian cancer. So for the next 20, 30 minutes, I'm just going to review with you what actually is HIPEC. What's the rationale for exposing patients to HIPEC at the time of surgery? What are some of the foundational studies that were done that would provide a signal, an aha moment that, hey, this may have some validity in terms of a value add for patients that we're trying to treat surgically, that may actually help what we're going to do long-term with patients with respect to adjuvant therapies. I'll review with you briefly some of the early outcomes, as well as some of the toxicities that we've observed with HIPEC. And then lastly, I'll conclude, where are we going with this? What are some of the future strategies? What are some particular areas of interest that you may wish to explore? You may have family or friends that may wish to explore in the near future. So it really all started with the delivery of chemotherapy within the peritoneum, within the abdomen and pelvis. And it really kind of made sense, right? The cancer that we're contending with respect to ovary or fallopian tube cancer or peritoneal cancer is within the confines, for the most part, in the abdomen and in the pelvis, and it's lined by the peritoneum. So it made sense to try to deliver this chemotherapy within that cavity. And this cartoon illustrates how the chemotherapy was administered through this port, and there was a catheter attached to the port that delivered the chemotherapy to this cavity. And in the late 90s and early 2000s, there were a number of trials that were enrolling patients exploring this potential concept. And the idea was, well, it improved drug delivery to the surface, with the hope that it would increase intensity of drug delivery and total drug exposure. And of course, the hope was that it was going to demonstrate an improved outcome and overall survival. And as I mentioned, there were several large prospective randomized trials. Probably one of the landmark studies was the study that was enrolled patients through the Gynecologic Oncology group mechanism. This was called GOG 172, and this was the publication in the New England Journal of Medicine back in 2006. And overall, this trial demonstrated a significant improvement in overall survival. And there was a great deal of excitement, but there was also some trepidation. And the trepidation came with the fact that there were a number of toxicities observed in those patients that were enrolled in the trial and that were randomized to the intraperitoneal arm. There were issues with nausea and vomiting. There was issues with electrolyte abnormalities. There were also a number of complications in regards to that port. The port would sometimes get contaminated. It would get occluded. The port could wander and get into structures that we didn't want it to get into. And so there was some concern that maybe although the survival was far greater in the IP arm than in just the intravenous arm, there were the toxicities might have degraded some of that, the vigor and the fervor over potentially pursuing intraperitoneal chemotherapy. At the same time, our colleagues in surgical oncology had been exploring the possibility of delivering chemotherapy at the time of surgery. And the hope was that it combined the advantage of delivering chemotherapy in that peritoneal cavity at the same time a patient was undergoing a radical operation to remove their tumor. And as I mentioned, our surgical oncologists were exploring this in similar tumors, such as cancers that arise from the appendix or from the colon. And the benefit was it was a single procedure. Surgery was performed, catheters were inserted, the chemotherapy was delivered, and this would hopefully avoid some of the catheter-related complications and some of the nausea and vomiting issues and neuropathy that we had seen with the intraperitoneal chemotherapy. This cartoon gives you just kind of a brief snapshot of what it looks like. At the completion of surgery, the abdomen is closed, but these catheters are inserted into the cavity. Chemotherapy is heated up by a machine, the Belmont, usually that sits in close proximity to the patient. The chemotherapy is infused. We at the bedside perform, for lack of a better term, a shake and bake, where we actually move the abdomen with this fluid that has the chemotherapy in it for 90 minutes, exposing all of the surfaces and hopefully all that microscopic disease to this chemotherapy. It's then aspirated and delivered back to the system. And eventually the fluid is aspirated, removed, the cavity is washed, the abdomen is opened again, the catheter is removed, and then the abdomen is then closed and the patient will either go to the ICU or to the PACU or to a step-down unit. And the rationale for heating up the chemotherapy, although not clearly understood, includes a number of these hypotheses. First and foremost, and we do understand this, that when you heat this chemotherapy and you heat this cavity, it actually enhances the penetration of chemotherapy. So the thought is that you expose these microscopic cells that were left after your long operation to remove all the visible disease to chemotherapy, and hence improve the effect of that chemotherapy at the time of the administration of whatever agent is actually infused into the peritoneal cavity. And we know that it actually may, in fact, improve the sensitivity to platinum, which is one of the common drugs that's used during a HIPEC procedure. There's also a thought that it stimulates the immune system, and there are particular cells that are really important in terms of recognizing something as abnormal. And the thought is that it potentially increases the amount of natural killer cells that are delivered or moved to these areas where there are these microscopic tumor cells. As I mentioned, this was first explored by our surgical oncologists in the late 70s, and it was specifically for patients who had appendiceal or colon cancer, and more importantly, those patients that had pseudomyxoma peritonei. This is this term we use called jelly belly, where there's gelatinous, mucinous debris material within the peritoneal cavity. And they knew at the time that their outcomes with respect to intravenous chemotherapy was not as robust and promising as they hoped. And they started this concept of delivering the chemotherapy based on some of the foundations that I just described. And they noted some relatively promising results specifically for appendiceal cancer. And it wasn't really until the 90s and late 90s, early 2000s that gynecologic oncologists began to wonder, well, can we do a similar process for patients with ovarian cancer? Some of these cancers spread very similarly to what our surgical oncologists are managing. And as such, maybe we should expose some of our patients with particular types of ovarian cancer to HIPEC. And in fact, this slide really kind of demonstrates that there were a number of single institution, really retrospective case control studies that began to explore this idea of heated intraperitoneal chemotherapy. And again, some of the results were very promising, but again, these were just signals, messages, like maybe there's a rationale or a role for this in patients with ovarian cancer. Where our colleagues in Northern Europe took the next step. And this was their work that was published in the New England Journal of Medicine in 2018. And in their particular trial, it was a randomized trial that they looked at women that initially were thought not to be the ideal candidate to go to the operating room immediately for surgery. So these were patients that were exposed to a few cycles of chemotherapy. They were then brought to the operating room for their primary surgery, or what we call an interval cytoreduction. And at that time, they were randomized, and they were randomized into a group that were going to receive HIPEC versus a group that weren't going to receive HIPEC. At the conclusion of their surgery, and after they'd recovered from their surgery, they then would complete the remainder 3 cycles of intravenous chemotherapy. They used cisplatin as their agent that they infused at the time of surgery. And they were interested in really 2 primary endpoints. The first of which, did it delay the time to which a cancer would recur? And did it also improve overall survival? And then lastly, what about the toxicities? Was there a difference between those that were exposed to HIPEC versus those that were not? And I want to show you first and foremost that in the past, we used to be, and I think Catherine demonstrated this in her early presentations, we were lumpers. We stuck all ovarian cancer into one big bucket, and we exposed everyone in that one big bucket to particular modalities. But we learned now that we really shouldn't be doing that. We need to be more splitters. We need to look at individual types of epithelial ovarian cancer and maybe treat them a little bit differently. And this, I think, illustrates not only the commonality of high-grade serous cancer, but really the focus of this trial was to look at this subtype that we thought potentially was going to be most amenable to intraperitoneal, heated intraperitoneal chemotherapy. What the trial demonstrated was that the surgeons, there were equivalent efforts to remove the bulk of tumor at the time of their interval cytoreduction. They performed relatively similar numbers of bowel surgery and bowel resections, but there were more colostomies or ileostomies that were performed in those patients that were exposed to the heated intraperitoneal chemotherapy. But probably the crux of what I want to focus on today is what were the differences that were observed. And you can see from this red line, these were the patients that received surgery and HIPEC compared to those that received surgery. And you could clearly see there was a gap. There was a difference between these 2 curves. And what this demonstrates is that there was a difference, a statistically significant difference in terms of time of recurrence. In fact, the time of recurrence was different by almost 14 months for those, 4 months for those patients that were exposed to surgery plus HIPEC versus those with surgery alone. More importantly, however, when we look at overall survival, you'll see the same curves, red consistent with the surgery plus HIPEC group, the black demonstrating the surgery group. And you'll see that there was a marked difference in median overall survival. In fact, there was almost a 12-month improvement in survival for those patients that were exposed to surgery plus HIPEC versus those that had just been subjected to surgery alone. And that was fairly substantial and a robust finding. Additionally, the investigators also demonstrated that there were similar complication rates in each of these groups. In fact, there was no difference in grade 3 and grade 4 complications, and relatively few differences in terms of length of hospital stay and ICU stay for those patients that were in the surgery alone group versus those that were exposed to the heated intraperitoneal chemotherapy. So the question that arose from this, and there was a great deal of interest, and it received a number of editorials in peer-reviewed journals, but the lay press really ran with this and talked a lot about this significant improvement in overall survival. And the question that arose was, well, this was a phase 3 trial. Phase 3 trials are typically the gold standard for evaluating new therapies, well-designed, seemingly unbiased, but did this lead to a practice change? Did clinicians throughout the world recognize this as a practice-changing trial? And what was happening in the US after this trial was published in 2018? So one of our fellows said, well, let's look at it. Let's see, was there a difference? And is there a rationale for potentially exploring this for patients in the US that are similar to the population of patients that were included in this phase 3 program. And what she looked at was a large database, and the database is not perfect, but the database includes about 95% of all academic medical centers. And she looked at the utilization of HIPEC for the 2 years prior to this publication, and then for the 2 years after this publication. Suffice it to say that there was a marked increase in HIPEC cases in the US for the subsequent 2 years after this publication. But then she took it one step further, and she wanted to look at, did the outcomes, did the length of stays, ICU admissions, complications, and costs, did they mirror what we saw was happening in that randomized trial? In other words, was this a safe practice? And did we find similar outcomes that were observed in Europe? And what she identified was that there were, again, more surgeries performed that included HIPEC post the 2018 publication. In fact, 97% of the cases in this review were completed after 2018, compared to a very few prior to this publication. Most, however, were being performed at 10 centers, 5 of which were university-based, 5 of which were community-based, but did have a significant academic presence. And this graph demonstrates the adoption of HIPEC after the completion and the publication of this trial. And you can see there has been a growing trend to explore this in the US in multiple sites and in multiple centers. But what she also identified was that in review of those patients that were included in this database, there was a bit of a longer median length of stay, a little different than what we observed in Europe, a higher percent of patients going to the ICU, a higher cost. There's also a bit of an increase in complication rates, but importantly, there was no difference in 30-day readmissions. One thing that was clear, that there was a need for lessons to be learned as programs began to adopt or consider adding HIPEC as part of their treatment strategy for patients with advanced ovarian cancer. And we learned some of these similar lessons, and I'm going to talk about that briefly at UCSD as we began to explore this possibility. And it's important to keep in mind, especially if you're looking for centers, that the success of this program is really based on a number of factors. The need for a multidisciplinary approach. We need anesthesiologists that are partners in the management of patients intraoperatively, because there are a number of nuances and significant differences when we start to expose patients to long operations followed then by 90 minutes of chemotherapy, that we need our colleagues in anesthesia to support and to assist so that we decrease the potential for complications postoperatively. Our nurses, our pharmacists, and I also would caution that our surgical oncologists have been doing this for 20 plus years, and leaning on their expertise has been, I think, very critical for us and for the success of our program at UCSD. And then lastly, there clearly are a number of standard approaches that really do facilitate and improve overall outcomes for our patients who are being exposed to HIPEC. So I briefly want to share with you our UCSD experience. And after the 2018 program, we began to explore, should we start to really dive into the realm of HIPEC and ovarian cancer? We had dabbled a bit with our surgical oncologists for years because our program at UCSD has been one of the renowned, recognized HIPEC centers in the world, and specifically our surgical oncologists exploring the use of HIPEC for appendiceal and for colon cancer, also for mesothelioma. And so we partnered with our surgical oncologist after this publication, and we made a concerted effort to start to explore the possibility of exposing our patients with ovarian cancer to heated intraperitoneal chemotherapy. This is just a brief snapshot of our very initial review of our cases. This was published in Gynecologic, I think, in 2020. And our first quick overview looked at our first 70 or so patients. And so we looked at our patients that were prior to 2018 that had been taken to the operating room for integral site reduction but did not receive HIPEC, versus our patients after 2018 who went to the operating room for an interval cytoreduction who were exposed to HIPEC. And what we noted was that there really weren't a lot of differences between the two groups. Similar ages, similar proportion of patients with stage 4 disease, similar choice of chemotherapy and total number of cycles. We applied a chemotherapy response score for each of those patients who had neoadjuvant chemotherapy and then underwent a cytoreduction, and we found very similar results with respect to the two populations. The one difference that we recognized, however, that there was a significant increase in the number of patients who underwent upper abdominal surgery. That include removing the diaphragm, removing the spleen, potentially removing a segment of the liver or the gallbladder. There also were a number of patients where we removed the lining that had miliary disease, kind of like a plaque-like disease, once we started this HIPEC program. In addition, the surgical duration was far greater in the group that were obviously being exposed to chemotherapy. Our success with removing all the grossly visible disease was quite robust after we initiated this HIPEC program with a complete cytoreduction rate of 95%, which is fairly high, but keep in mind, this is a small cohort of 20 patients. And then lastly, we also noted that there were more grade 3 and grade 4 complications at a rate of 65% to 2%, which we observed in our two cohort of patients. The other thing that I was very interested in was, well, how did our patients do afterwards? And what we found, and again, it's a small subset of patients, that we identified a cohort of women who had seemingly a great response to their chemotherapy. They underwent a really aggressive operation. They were completely cytoreduced. They then started their chemotherapy post-HIPEC. And we found that in this cohort, 4 patients actually were diagnosed with platinum refractory disease, meaning their tumor grew when they start to be exposed to chemotherapy again after their HIPEC. And it made us pause and it made us question, well, why was this? And right now we're taking a bit of a deeper dive to explore specifically why was there a difference in this particular 4 patients who were exposed to HIPEC, that they had an earlier recurrence than we would have ever anticipated based on clinical factors, intraoperative factors, and their response to their neoadjuvant chemotherapy. And we're looking at them from a biologic standpoint, their tumor prior to surgery compared to their tumor post-surgery compared to their tumor post-exposure to HIPEC. So where are we? I don't know if it's practice changing yet. I still think that HIPEC needs a bit more further investigation. And I think there are a number of individuals that would agree with this assessment. In fact, if you were to look in clinicaltrials.gov, there are now 30 trials listed, 21 of which are actively recruiting patients. There are a number of populations that are being explored, that HIPEC is being explored at the time of primary surgery, meaning patients that we say, yes, they can undergo a large cytoreductive effort, a big surgery, and then get their chemotherapy afterwards. And those patients are being considered for HIPEC versus interval cytoreduction, like I just discussed with you, versus patients who recur that are taken back to the operating room after their surgical effort. They're then being exposed to HIPEC. There are also multiple agents and combinations that are being explored, as well as maintenance therapy. It's important to keep in mind that we don't function in a vacuum. Why that trial by Vandriela and colleagues was accruing patients and published in 2018, there was a rather extensive evolution in biologics that were available for patients, as Dr. Foot had shared with you. And we need to figure out a strategy by which the same maintenance therapy can be included in these trials that are exploring HIPEC. And that's exactly what we're seeing in the near future. And I want to bring to your attention 2 studies. This is a study that's being done in Europe. This is looking at patients who have stage 3 disease. They are taken to the operating room and they're going to undergo a cytoreductive effort, try to remove as much tumor, again, randomized to HIPEC or no HIPEC. They're then going to be exposed to chemotherapy plus or minus bevacizumab, which Dr. Fu had alluded to earlier in her presentation. And then some of these patients, depending on their eligibility, will also be exposed to a PARP inhibitor for maintenance or bevacizumab for maintenance therapy. This trial is enrolling patients now in Europe. And lastly, the GOG, after a number of efforts and modifications, have proposed the following trial that are looking at particular sites, and I'm certain UCSD will be one of the sites for this particular trial. And they are again looking at patients that are considered really not eligible for primary cytoreduction. These are patients that probably would do better with a few cycles of chemotherapy. So they're exposed to 3 cycles of chemotherapy. They're then going to be taken to the operating room to undergo surgery. They'll be randomized to HIPEC, again using cisplatin or no HIPEC, and then they'll complete 3 additional cycles of chemotherapy. And then lastly, they'll have the opportunity to be exposed to maintenance therapy, just like someone who's not included in any of these clinical trials potentially could be exposed to PARP maintenance therapy. And so this trial is, I think, going to bring together novel intraoperative management with HIPEC, plus the novel emerging therapeutics that we are finding success with respect to advanced stage epithelial ovarian cancer. One of my favorite quotes from Albert Einstein: if we knew what it was we were doing, it would not be called research, would it? We still have a while to go with respect to whether or not HIPEC should be standard of care, but we're moving there. We're inching towards ascertaining whether or not this is a value add. Should it be brought together with some of the novel therapeutics that patients are being exposed to? And I'm excited about where we're going. I'm excited about the opportunities that we have for our patients with ovarian cancer. And at that, I'll conclude and would welcome any of your thoughts, questions, comments, concerns. Thank you.
Thank you very much, Dr. McHale. I think that you've done a lot of groundbreaking work in GYN oncology, and especially in our California community. I agree with you in terms of the entire collaborative process. We certainly have been working with our surgical oncologists and then partnering with anesthesia, perfusion, et cetera. Questions that come from the chat include, these studies are looking at HIPEC at interval debulking surgery. And so there's a question about kind of timing in terms of if HIPEC has been studied at the time of recurrent setting at the primary surgery. So, where is the best place to use this technology? And obviously we have to study it one at a time, but just thinking about that, what do you think?
We don't know when is the best time to expose patients to HIPEC. So the only randomized trial we have is the one that I just demonstrated, and that was done at the time of an interval surgery. So a few cycles of chemotherapy, go to the operating room, big surgical effort, then expose intraperitoneal chemotherapy, and then complete your remainder of your intravenous chemotherapy. But there are many that raise the same question: well, why can't we move this up? Why can't we do this for patients that are really good candidates to go to the operating room for a primary cytoreduction, meaning before they've been exposed to any chemotherapy whatsoever? And why don't we explore that particular cohort of patients and expose them at the time of surgery to HIPEC? And there are trials now, as I showed, that are enrolling patients to move it up a little bit more into the front line, as opposed to this interval approach. There are also trials that are looking at patients that are potential candidates for a second cytoreductive surgery, and that may be patients who have had chemotherapy a decade ago and now they have this really odd recurrence, and these are patients who have a very small focus of disease that their physician thinks that they may be a good candidate to go back to the operating room to remove that tumor burden, and at that point expose them to HIPEC. So we have really 3 buckets of trials that are ongoing, that will be ongoing with respect to when do we expose patients to HIPEC. But at the same time, it's really important that they marry these trials to novel therapeutics, which is what we're seeing. And that's important because, as Dr. Fu had demonstrated, we have really moved the needle for ovarian cancer, and moving the needle for ovarian cancer has exposed patients to these novel therapies like PARP inhibitors. And we really shouldn't exclude patients in these trials that are going to be exposed to HIPEC. We shouldn't keep them from receiving some of these novel therapeutics that clearly have demonstrated a benefit. And so now we're bringing them all together, which is making these trials a little bit more challenging, but it's really kind of exciting in terms of where we're going.
So I guess in complement to that, because you talked about targeted therapies, do you consider patients with characteristics such as pathogenic variants in BRCA1 and 2 to be equally benefiting? And I guess, of course, this is a research question, but do you manage all those people the same in terms of someone who has a great response to platinum, someone who's BRCA positive, someone who seems to have, more stable disease that requires more debulking? Do you take that into consideration when you offer patients HIPEC, or in a trial setting, I guess you would take them all?
In a trial setting, we take them all depending on, obviously their inclusion characteristics, but the GOG trial is really going to take them all. When we first started this program, we took them all, and we decided more recently that we were going to kind of modify which patients that we thought were better candidates if we were going to include to expose patients at the time of interval surgery. Clearly, we're going to try to enroll patients on trial once the GOG trial is open. But you would think that patients that were homologous recombinant deficient, whether they're BRCA positive or they're just HRD for some other particular reason, that they are profoundly platinum sensitive. And the thought is, well, maybe by exposing them to this heated chemotherapy, specifically platinum, you may in fact have a more of a benefit because just purely based on their biology. I don't know if we know that answer yet. We are now going back retrospectively to look at this entire cohort, as I mentioned, from a profiling standpoint and marrying it together to their genetics as well to see if we could ascertain, was there a difference? And why did 4 of our patients that seemingly really were very platinum sensitive, very responsive, did they recur in such a short window of time? And how did they differ from the other patients that had not just a robust response, that had a really prolonged progression-free survival after exposure to HIPEC? So I think there's more to come with respect to that, Lime.
Yeah, that's really interesting. And obviously the translational component is going to be very important, and understanding how the tumor environment changes too with the HIPEC. One last question before the break, which is that there's a member of the audience who wants to know your thoughts about HIPEC, which I understand is like pressurized intraperitoneal chemotherapy.
Pressurized intraperitoneal chemotherapy. I'm not certain I know what pressurized intraperitoneal chemotherapy is.
Pressurized intraperitoneal aerosolized chemotherapy.
So yes, okay. The aerosolized helped it for me. Thank you. So there is a small contingent of investigators in Europe that have looked at modifying this exposure. And the thought, again, it's all based on some small preliminary animal models, which is hard to believe they're able to do this, looking at pressure and how pressure may in fact induce a higher yield or a higher exposure to getting chemo where we want it within the tumor cells. And I have to be honest with you, there's just not a lot. It's really in its infancy in terms of exploration, and there's just not a lot of detail with respect to this modality and how it may be better than just the hyperthermic intraperitoneal chemotherapy. Our surgical oncologists had considered this as a potential strategy for a trial, and I think they've decided to abort that concept because it was actually being explored for colon cancer. We know there's been some differing outcomes with colon cancer and hyperthermic intraperitoneal chemotherapy. So that's all I can really comment on the pressurized chemo piece.
Great. Thank you very much. Thank you to both Dr. McKeel and Dr. Fu for this fantastic opening session. I hope that we've broadened both translational science and surgical medicine. We're going to take a 10-minute break, and then we're going to come back with our next session to give you some tools and think about some wellness. So we're going to put up the slides for the wellness break and be back in 10 minutes. Thank you so much. Hi, everybody. We're going to try and stay on schedule. I'm going to let people kind of walk back into the room. I hope everybody had a little bit of wellness or at least a bio break. We had the slide up that talked about the breakout rooms. They will start at 12:15, but they're up there so you can take a look and see what you're interested in joining. You're welcome to join more than one, and the videos will also be online at the end of the symposium in the next few days, so that you can always refer back to them as well. Let's see. Oh, I also wanted to give a shout out to our sponsors, GSK and Myriad, one more time. Myriad will be joining the Friends Circle breakout room. So for those who are interested in getting some more information, you can go there at the time of the breakout session. Our next section is going to be some talks on improving care and resources and kind of moving along the journey. So we talked a little bit about science and surgery. And next I'd like to introduce Dr. Stephanie Cham. Dr. Cham also recently joined our faculty in the division as an assistant professor. She is also doing a women's health research scholarship program. And Dr. Cham was a resident at Columbia and completed her fellowship in Boston at Brigham and Women's and the Dana-Farber Cancer Center. She's going to be speaking us today on her research interest, which is improving care for the frail and elderly population with gynecologic cancer. Dr. Cham.
Thank you guys so much for having me and for letting me share something that I'm passionate about, and hopefully you all will learn a little bit more and find some interest in this topic as well. So what I'll be talking about is frailty and its impact on the management of gynecologic cancers. And just as an overview, we'll be talking about really defining what frailty means and who it affects. And we'll be exploring the impact of frailty and briefly talking about methods to support frail patients. And so I think one of the first most important questions we really have to ask ourselves is, what does frailty mean? And these are two nice pictures that I think really helped us understand and kind of depict what frailty means and how it affects our patients. We really think of it as a cyclical state of diminished physiologic reserve, resulting in a decreased adaptive capacity and resilience to stressors. And so one of the kind of analogies that I often see used is kind of like a spring system here. And as our patients go from fits to pre-frail to frail, they eventually have a poor adaptive capacity and resiliency to stressors. And this picture on the right really talks about what we think of as a cumulative deficit frailty. And some propose that there is a cumulative deficit that arises from a variety of medical, social, and functional deficits that eventually lead to frailty. And importantly, I think it's really important to highlight that frailty may or may not be age-related. So some of these stressors that lead to frailty may or may not be due to age. And this figure really highlights that frailty coexists and overlaps with previous disability as well as chronic disease. And that when chronic disease includes cancer, patients are at an even higher risk of frailty. And that's why we see such high rates in our cancer patients. And so we really think of frailty as a state of extreme vulnerability to stressors that leads to adverse health outcomes. In reality, we know it's a much more complex physiologic, psychologic kind of issue. We think that approximately 50% of cancer patients are either considered pre-frail, so that means at risk, or frail. And some of this can actually start prior to your cancer journey or start to accumulate and occur during. And as I said, this typically is associated with older age patients, but younger patients can really experience frailty as well. And this is particularly seen in the context of cancer. So what impact does frailty have on our patients? In terms of specific oncologic or cancer-related issues, we know that frailty has significant impact on many dimensions. So this includes surgery. We've seen in many studies that frail patients have an increased rate of postoperative complications. This includes ICU admissions, increased hospital length of stay, readmission, and increased discharge to nursing home and facility. We also have seen in terms of chemotherapy, increased toxicity and decreased tolerance, as well as treatment delays. And we know that for frail patients, it can be very difficult to be involved in clinical trials and be enrolled for clinical trials because they may not always meet the inclusion criteria. And importantly, we've seen overall outcomes are also affected. So this means a reduced quality of life, a loss of independence, and in some studies has even been shown that frailty is associated with an increased disease progression and decreased survival. This table here really highlights something else that I want to talk about. And really outside of the context of cancer, there are multiple other general adverse health outcomes that also pose significant changes to function and quality of life for our frail patients. So this means our frail patients may also have an increased experience of falls, disabilities, cognitive decline, functional dependence, institutionalization, social withdrawal, and death. And this is even outside of the context of just cancer itself. So one of the questions we often then get asked is, how can we support our patients who experience frailty? And one of the first really important steps is really identifying frail patients. So the utilization of screening is really our first step. And one of the major issues we've seen with this is frailty screening is very complex and very wide-ranging. So there are various numbers of screening tools. This includes the Frail Scale, the Vulnerability Elder Survey, Phenotypic Frailty, the Modified Frailty Index, cancer-specific geriatric assessment, et cetera. There's a very long list of screening tools. And really the main issue is they're both underutilized and inconsistently used. So one clinic may use one form of screening, another clinic may or may not use a different form of screening. And there are obviously a number of various pros and cons to each of them. One of the major barriers that people cite to screening for frailty is really the time it takes to perform this testing, and also the ease of use of some of these screening tools. There are also some interesting studies looking at novel mechanisms to screen patients for frailty. So this includes CT scans that examine patients for sarcopenia, which is known as low muscle mass, biomarkers, which are blood tests that help us maybe determine who might be at risk based on some blood studies who are at risk or are frail. And there are also some studies looking at mobile apps to see if we can use smartphones to really track patients and see if they are at risk or experience signs of frailty. These are two screening tools that I just wanted to compare, and that's because they're different, but are screening for the same thing. This is called the Frail Scale, which I think of as more of a subjective scale. So it asks patients specific questions and asks them, do you experience some of these things, including fatigue, resistance or difficulty climbing stairs, ambulation, illness, and loss of weight. This is called phenotypic frailty, and this is what I consider a more objective score. So it really looks at specific measures that we can measure ourselves to look for weight loss, weakness, exhaustion, slow gait speed, and low activity. So as you can see, different forms of screening patients for frailty are very wide-ranging and different in terms of how time-intensive and how complicated they can be. The second step is really promoting pathways and multidisciplinary teams to improve surgical outcomes and the delivery of chemotherapy. And what we really think of this as is individualization of care. So once we've identified that someone is either pre-frail or frail, how can we individualize their care to really promote improved outcomes? So in terms of surgery, what people are proposing are using multidisciplinary pathways to really improve outcomes. And this is a review in one of our major oncology or cancer journals of how we can use 6 specific patient-centered changes in our surgical pathways here to improve functional outcomes. And really the end goal is something we call functional recovery, which really means outcomes that patients care about, such as function and independence. And so the 6 patient-centered moves are labeled here, 1 through 6, but it's really looking to see how can we improve different parts of surgery to improve outcomes. So increase utilization of minimally invasive surgery when appropriate, because we know patients recover much better from minimally invasive surgery when we use it. This also means using enhanced recovery pathways that a lot of hospitals are now utilizing to improve postoperative pain and increase speed to recovery. Other examples of how we can use this pathway are frailty screening, which we previously talked about, the use of rehabilitation, so strength training after surgery, and prehabilitation, strength training before surgery. And then the 6th step that they propose is improving social support for our patients after surgery. And as you can see, it involves a number of different providers, ranging from geriatrics to our medical and radiation oncologists, to our surgeons, to our anesthesiologists, to our physical and occupational therapists. And as well as our case managers and social workers. So this can be very complex and requires a lot of teamwork, but we know can also really help patients improve their functional outcomes at the end of surgery. In terms of chemotherapy, we know that a holistic and integrative approach has been shown to reduce serious chemotherapy toxicities. So this is a figure from a study that was published in one of our major cancer journals, where patients were randomly assigned to receive care from a multidisciplinary team that implemented the above kind of interventions versus just normal care. And they basically showed that when patients were assigned to receive this specialized multidisciplinary approach using this holistic integrative approach where patients were screened for the following deficits in all of these various domains, that patients actually were able to have reduced serious chemotherapy toxicities. So when we look at all these different areas that patients could potentially be affected by, they actually found that when they screened patients for all of these things and implemented these interventions, they were able to tolerate their chemotherapy better. And then the third kind of important part of helping our frail patients is really the early involvement of symptom management or palliative care. And the reason that we think of promoting palliative care is important is because we know that early referral and utilization has improved outcomes for frail patients. This is a nice figure that they actually published in one of our major cancer journals for providers, really kind of using a metaphor to describe the difference between a late palliative care referral and an early palliative care referral. And the analogy or metaphor that they're making here is that palliative care is much like an umbrella. It's really nice to have an umbrella ahead of time and ready when the storm comes. And patients are much happier when they have it and are glad when they had it available, versus not having the umbrella, getting soaked in the rain, and then having the umbrella after. So we often think of palliative care as a really important tool because when we really need it, we're really happy we have it ahead of time. And so this was a metaphor that was published to really encourage our oncology providers to help our patients get an early palliative care referral. And some of the reasons why we recommend promoting palliative care or symptom management early on is because we've seen in many studies that patients have improved long-term outcomes. This means an improved quality of life, decreased psychological distress, improved end-of-life care, and have even been shown to have improved survival when they have an early referral. We've also seen that early referral to palliative care improves surgical outcomes and has been shown in many studies to reduce complications and death around the time of surgery for frail patients. And this really means ensuring patients and providers have the same goals of care and also making sure that we have advanced care planning in place prior to surgery. These are some of the interventions that I just wanted to bring up that are either in progress or currently active at UCSF. One of the major things that we've done is the symptom management service has become very involved with our Gynecologic Oncology clinic. They've been promoting early and regular screening and actually have hired a new provider that will work exclusively with just our G1 oncology patients and provide consultation services and close support. And I know that's something that Dr. Chen has worked very closely with our symptom management service on. Our geriatric team has also been closely involved with our clinic and has started to implement geriatric needs screening. And with this screening system, they basically recommend either referral to geriatrics or other services, such as social services, physical therapy, or anything else that's needed. And then the third program that I'm particularly working on is a prehabilitation program. So prior to surgery, optimizing nutrition and muscle mass and strength in preparation for surgery. So those are some of just kind of the active things that we're working on at UCSF because we know that our frail patients will definitely do better if we implement interventions to help promote improved outcomes for these patients. I apologize, I haven't been monitoring the chat, but I will stop my screen sharing here and see if there are any questions or anything that people specifically want to address.
Thank you very much, Dr. Cham. I think that what we want to do is bring in a multidisciplinary approach to our patients perioperatively and postoperatively. And I think that developing the appropriate interventions is really what's going to make the difference. We've recognized for some time now that there are patients who are at higher risk, and we look to things that we can do to make their course easier. And as you said, get them back to their full recovery.
Thank you.
All right. Thank you very much. Our next speaker is going to be Dr. Allison Jang. Dr. Jang is our second-year clinical fellow here at UCSF. Many of you know that we have a training program that we share with Kaiser Permanente San Francisco. And Dr. Jang joined us over a year ago. She did her residency at UC Davis, so all part of the UC family, and will be speaking to us on weight management. We know that the obesity epidemic is something that affects gynecologic cancers and health overall. So we wanted to address that with the audience today. Dr. Jang.
Thank you, Dr. Chen. I will share my screen. All right, perfect. Yeah, so once again, my name's Allison Jang. I'm one of the clinical fellows here at UCSF, and I'm excited to be speaking to you today about weight management and how it relates to gynecologic cancers. Obviously, weight management is a very wide topic, and so I'm only going to be really scratching the surface today. But I hope that this topic sparks some questions, some discussion, and I've also provided some resources within the PowerPoint. There are many QR codes, and you'll have access to the slides after the program to be able to review those resources on your own. And so first, just for some overview. So first I'll be talking about how we measure weight status, as well as how weight affects cancer and its outcomes, and then reviewing some of the principles of weight management and strategies for implementing some of these principles into your daily life. And as I said, also providing some additional resources for you to review at your leisure. And so first, in terms of measuring weight status, there are a couple of different ways that we evaluate this. In medicine, we know that having a high amount of body fat can cause many related diseases or other health issues. You may have heard of a measure called a body mass index, also known as BMI, which is a more objective screening tool that we use to estimate weight status in relation to potential disease risk. And so BMI is calculated by using a person's weight divided by their height squared. And this QR code is a way for you to access an actual calculator and calculate it yourself. Essentially, when a person's weight is higher than what's considered a healthy weight for their height, this can be described as overweight or obese. And so having a BMI between 25 to 29.9 would be considered overweight, versus having a BMI greater than 30 would be classified as obese. And this can be subdivided into different classes of obesity. And so from now on, I'll be, when I refer to obesity, that will be referring to a BMI greater than 30. And so within the United States, we know that the prevalence of obesity is increasing from 30% back in 2000 to 41% more recently in 2020. Obesity impacts some groups more than others. This map is of the United States. And so you can see that the darker orange, more red colors indicate areas with a higher prevalence of obesity. And so definitely a higher prevalence within the Midwest and the South. And this is followed by the West Coast, as well as the Northeast. Obesity is a very complex disease. And so there are many factors that can contribute, external factors that can contribute to this. That could be as simple as like a neighborhood design, or access to healthy foods, or access to a safe area for physical activity. But later in the talk, we'll talk about some of the strategies and resources you can use to help achieve your desired weight management goals. And so why do we care about obesity? We know that there are long-term health outcomes associated with this disease that can cause other diseases, diabetes, high blood pressure, or high cholesterol, also heart disease, sleep apnea, arthritis, are just some of the chronic conditions that we see. Also malnutrition. Dr. Sham talked a little bit about nutritional status and its relationship to frailty, and malnutrition commonly exists with chronic diseases as well as actually with obesity. And we know that 20% of our cancer patients, including those that are obese and overweight, will be malnourished at the time that they see us, lacking nutrients such as like vitamin D and biotin, vitamin C. And also cancer in itself can be very demanding to your metabolic system and cause further depletion of these. And in addition, we care because obesity can also affect your cancer treatment. For surgical interventions, we know that there are higher rates of perioperative complications, increased rates of needing to convert from a minimally invasive surgery to an open surgery, and requiring more intensive postoperative care. For chemotherapy, body weight can determine the safety and effective administration for a lot of our chemotherapy agents. In addition, obesity can cause impairment in renal function or kidney function. And as a result, that can affect the dosing and the clearance and toxicities that patients experience with their treatment. And then also radiation. The radiation needs to actually hit the tumor in a very precise manner to be effective. And so with obesity and having an increased distance between the tumor and the skin surface, sometimes they need to do higher doses of radiation, which can also cause toxicity to other organs as a result. And then finally, we also know that having an increased weight can affect cancer outcomes. And this has been seen in many of our gynecologic cancers. Particularly for endometrial cancer, we know that there's a 10 times increased risk of developing endometrial cancer when obesity is present compared to non-obese women. There are higher rates of mortality or death from cervical cancer compared to normal weight counterparts. And in ovarian cancer, there's a 17% greater risk of dying from ovarian cancer compared to patients with a normal weight. And so quickly reviewing some of the mechanisms of how obesity actually increases the risk of developing cancer. We know that obesity increases the risk for not only gynecologic cancers, but also like kidney cancers, thyroid cancer, breast cancer, esophageal cancer, particularly the relationship with gynecologic cancers primarily happens, we think, through these mechanisms, one being hormonal changes. Fatty tissue contains an enzyme that turns steroids in your body into estrogen. And so this can promote the growth of cancers that respond to hormones, particularly some types of uterine cancers or ovarian cancers. Another mechanism is inflammation. Living with obesity is a heightened inflammatory state. And so as a result, this leads to the inhibition of some of the mechanisms that cause abnormal cells to die and also increases cell growth. And so particularly in patients with certain types of cervical cancers, one called adenocarcinoma, it was found that women are twice as likely to be diagnosed with this particular type of cervical cancer when obesity is present. And then finally, this condition can also influence various metabolic pathways. It can cause lots of changes in the metabolism, as you may have heard of the protein called insulin. And so having high levels of insulin or insulin resistance, also promotes tumor growth, similarly through stimulating cell proliferation. And so just to review some of the principles of weight management, having a cancer diagnosis can change everything and really shift priorities in terms of focusing on health. And so one of the ways to stay healthy is maintaining a normal body weight. And so that's what we want to help you all promote in your daily lives. And so the first one of the principles is establishing healthy eating habits and reducing the number of daily calories if you are at an increased weight. And so things that can help with this are keeping a food diary and actually counting calories each day to make sure that you are objectively measuring where your intake is. Portion control. Another simple way to help monitor this is to implement something called the plate method, where essentially half of your plate is occupied by non-starchy vegetables, and then the other quarters contain proteins as well as carbohydrates. It is also helpful sometimes to either weigh or measure your food, but I know that can be challenging with daily activities in life, and so the plate method can sometimes be more realistic to integrate into life. Also reducing unplanned eating, avoid drinking calories. So this can be like sodas, juice, also alcoholic beverages like wine or beer are very high in calories. And so instead opting for a 0-calorie drink or just water. And then also avoiding eating after dinner time. And as I think more realistically, if you know that there are high calorie items that you particularly have an affinity for, stopping 1 to 2 of those can make a big difference. Really, a lot of it is controlling your environment, either not bringing these foods home or avoiding eating out. Sometimes people find it helpful to implement a weight management program, such as Weight Watchers, that can help you make just healthier choices. And also they can help manage your caloric intake. Particularly with other chronic health conditions, it's important to talk to your doctor and nutritionist about particular dietary changes that can be helpful. So for hypertension in particular, the DASH diet is commonly recommended, and this focuses on a low salt diet. For diabetes, making sure that you're intaking good carbohydrates, so ones that are not processed, or having a diet that's high in fiber is also a big focus for those measures. The second principle is starting a consistent exercise program. This can be very challenging and also very frustrating, particularly since we know that exercise does not cause quick short-term results. However, we do know that in the long term, this is helpful for maintaining your muscle mass and your strength. In addition, exercise also helps with your mental health, managing diseases like hypertension and diabetes, and also can help control pain. And so a goal to eventually aim for is 5 to 6 days a week, including 2 sessions of weight training. And there are lots of different resources available online that go over recommended physical activities. The WHO has a nice website that's based on age as well as chronic conditions, that makes recommendations for different types of activity. And I'll leave this slide here for for reference that you can look at later in terms of what they say they will classify activity as moderate or vigorous. And so these are some examples of what might be considered moderate or vigorous for individuals when you're looking at those other resources. I think number 3 is probably something that is challenging for a lot of people, but also making sure that you're maintaining your wellness and making yourself a priority. Things like getting adequate sleep and actively managing your stress, getting counseling or other resources as needed are things that are easy to put aside, but really important things for weight management. And then our last principle is finding your support system. This can come in many different forms. So family, friends, coworkers, having an exercise partner, your medical team, so your primary care doctor and endocrinologist, your GYN oncologist, also nutritionists and therapists, and the list goes on for sure. But I think that one thing that we're trying to do here is really increase our education. We know that from large surveys that nearly 60% of patients were not aware that obesity increased the risk of developing conditions like endometrial cancer. And actually in this very large survey over thousands of patients, only 37% reported that their healthcare provider had discussed the relationship between increased weight and gynecologic malignancies. And one of the barriers to this is in terms of our training and education. We know that in terms of gynecologic oncology providers, 40% didn't feel comfortable or adequately prepared to counsel patients on weight loss strategies. And so actually at our institution, last year, we implemented a fellows quality improvement project where our division actually received training from the director of our weight management clinic here on having these discussions. We also created a educational video which talks about the association between obesity and endometrial cancer to start as our focus here. And then we are also offering referrals to patients to partner with the weight management clinic if that's something that they're interested in. And so for our progress, we were able to successfully increase our education. Like I said, we're focusing primarily on endometrial cancer patients, but we went from 0% documented education to 80%, so a pretty decent increase. And then also of the patients who received the education, the majority of them also accepted referrals to the weight management clinic, which is great. And so this is the website for the weight management program here. You can scan this QR code at a later time. And then additional resources quickly. This is an obesity toolkit from the Society of Gynecologic Oncologists that you can use this QR code here to access that toolkit. Also, the CDC has lots of great resources, fact sheets, also other prevention strategies, more specific information on diet and nutritious foods. And those were all of my slides. I'm happy to take any questions.
We're actually going to move on so that we can continue the session. Thank you, Dr.
Yes,
Keating.
great.
There are a couple of questions in the Q&A, though, if you don't mind helping with those in the chat. We want to move along in our journey and talk about who I think are probably some of the best tour guides in the patient's journey, and those are our social workers. And so we have I have the pleasure of introducing Golda Hernandez, who is our social worker for the GYN cancer program here at UCSF, as well as one of our community partners who I got to know through the Cancer Committee, and that's Oliva Carpenter from the American Cancer Society. Golda and Oliva, a few minutes for discussing social work.
Thank you so much, Dr. Chen. So I'm not sure if I can share my screen, but I just wanted to give a brief highlight and overview of what I'll be talking about in our breakout session. And so again, my name is Oliva Carpenter. I am from the American Cancer Society as a Strategic Partnerships Senior Manager, and I partner with UCSF through their Cancer Committee. So today I'm just going to be talking about some cancer information, like our National Cancer Information Center, online resources, access to care, including lodging and transportation updates, how to order materials, and then how to get involved regionally, locally in our in the Bay Area, and then just some time for Q&A. So I'll just be giving just some patient resources updates that may be helpful for patients going through this journey. Thank you, Golda.
Great, thank you. And I will be joining you as well. And we, as social workers, we really try to meet you where you are in your cancer journey. And what might that mean? And for me, today we'll go over what supports we usually can offer. Usually it's two buckets, two different types of support: practical support as well as emotional support. And so today I'll be reviewing some resources around transportation and lodging, types support around insurance, financial benefits, and some resources we have around advanced care planning. And in the emotional support category, we do provide individual therapy referrals, support group referrals, such as the Friend Circle or the UCSF Gynecologic support group that I facilitate, as well as some of the other community partners that we have that also run support groups, peer support and community support programs, as well as caregiver support. So we look forward to seeing all of you at our breakout session later today.
Thanks, Golda and Oliva. That breakout session will be following the conclusion of our webinar portion of the symposium here. I next have the pleasure of introducing Redwing Kaiser, who comes to us from the Mary Center, which stands for Making Education Relevant and Integrated. Redwing is she is a nurse, a palliative care provider, a clinician, an author, a poet, and all in all, a lovely person. And we wanted to let you all know a little bit about what Mary does. Last year, I think you heard BJ Miller speak on palliative care, and I wanted to give a little attention to Redwing and our program here.
Thanks so much, Lee May. Can you hear me? Okay.
Yes.
All right. That was an old picture on that screen. And just for clarity's sake, among those other lovely things that Dr. Chen mentioned about me, I want to also just have you understand that I too am an ovarian cancer patient, and luckily I have made it through almost 10 years and I'm feeling great. So just to sort of the brief version of what the Mary Center is, MERI. We are a Center for Palliative Care Education at UCSF. We are a philanthropically funded program, so we're a little separate from the Division of Palliative Medicine, but we are part of the division. Some of you may have known Mary Jane Block, who was had breast cancer and lived for 26 years and was an incredible advocate for women in the cancer center with all cancers for many, many years. And her goal really was about making sure that everyone who treated her on her team treated her as a whole human being, and that she could also see her clinicians as whole human beings. And so part of the mission of the Mary Center is just that, to make sure that we really see each other as all of who we are. And for those of you who might be scared by the word palliative care, it's not just about end-of-life care. Really, palliative care is about including all the levels of suffering that happen when you have a serious illness, emotional, spiritual, psychological, social, as well as the medical aspects of pain and symptom management. But it's really addressing all those things, again, as a whole person. And unfortunately, a lot of people think palliative care is only for the end of life. People think it's the same as hospice. It's really, really not. We have amazing outpatient palliative care resources at UCSF. If you're a patient here, the symptom management service, and then other outpatient services to really help with pain and symptom management while your oncologists are focusing on your treatment all at the same time. So just to not be scared by that word palliative care, it's a crazy making word. The Mary Center, and Kevin was going to put our website in the chat, I believe. Hopefully next year I can do a full breakout session. Every month I offer advanced care planning workshops on Zoom. It's a 2-part series. Probably many of you have already attended it. It's a way to talk with other people about doing a really meaningful advanced directive for healthcare, understanding how to make it meaningful, how to have conversations with the people you need to have conversations with. It's a 2-part workshop. All of these things can be found on the Mary Center website. And Kevin was also going to put my direct email, and Gail Kojimoto's, who's the manager of our program, if you have questions. 3 times a week, I offer poetic medicine workshops, which are an amazing way to understand our own fears and feelings about what we're going through. One is specifically for grief and loss, one's for the wounded healer that targets clinicians a bit more, and one's for resiliency. We tried doing one specifically for GYN oncology, and we couldn't quite get it off the ground, but if people are interested, again, I am certainly open to offering that on some kind of regular basis, maybe even just once a month. Judy Long, our chaplain, offers resiliency courses, both for patients and for caregivers, that are amazing courses. And there are lots of other things happening. When you go to the Mary Center website, you'll see all of the educational offerings that we have. We really want to be there to support patients, to support family caregivers, and to support clinicians. We're working now on a communication pilot program in the Cancer Center with teams of clinicians, just to help us all get more comfortable with these really difficult conversations about serious illness. For some of us, it's about end of life, but how we navigate the system and how we navigate our own feelings when we have a serious illness. So I hope to see some of you at a workshop, and always just such gratitude to all of you who put on this GYN Oncology conference every year for, I think it's 10 years now. Thank you, thank you, thank you. Thank you for all the care that I receive from this team. Health and blessings to everyone.
Thank you, Red Wing. I want to give everybody a chance to stretch. We're a few minutes behind, but we're going to take 5 minutes to stretch. And we're going to move on our journey to talk about caregiver support. So if you're watching with your team at home, grab your family members and your caregiver team, and we're going to come back and talk to Amy Sachs from Share It. We'll see you in 5 minutes. Hi, everybody. I have the pleasure of introducing a member of our friend circle. As I mentioned earlier, we have a group of patients who work really closely with us in thinking about what's important and what is needed in our patient care community. We talked about this being a journey, and without taking away any of Stacy or Amy's time, I wanted to introduce Stacy Ross, who's here to introduce Amy Sachs. Stacy.
Thanks, Dr. Chen. Hi, everyone. Thanks so much for joining us today. I'm Stacy Ross. I'm a member of the UCSF Friends Circle, and I am here to introduce to you our next presenter, Amy Sachs. Amy is a social worker and program manager at Share It, where she supports families and patients who are going through breast and ovarian cancer. And she's going to talk to us today about how to strengthen your caregiver and your support circle. We know, it's such a huge part of the patient experience. So we're really excited to bring this all to you today. And I want to thank Amy for sharing this with us as well. Just a quick housekeeping note. We are going to address all the Q&A. If you have questions, we're going to bring them over to the breakout session at 12:15 Pacific. So feel free to continue the conversation there with us. And, if you do have questions, just put them in the chat and we'll make a note of them and address them over there. All right, so take it away, Amy.
Thanks so much, Stacy, and thank you so much for having me. So far, all the sessions today have been so informative and engaging, so I'm just really honored to be here. So Stacy summed it up really perfectly what I'm going to be talking about today. So let's get on with it. Oh no, it's not. Okay, there we go. So just quick about Share It, where I work. We are here for all of you. So definitely, feel free to get in touch at the end. I'll share my email and I'll put it in the chat as well. We are a Jewish organization, but we're absolutely here for everybody, regardless of background. So if you don't identify as Jewish, we are absolutely still here for you. We don't bring up the Jewish piece, but because the Jewish community is at increased risk, we can offer a little bit of added support around how spirituality and Judaism can, come into confluence with your cancer experience. We're also here for people who don't have a cancer diagnosis, but maybe only are interested in genetic testing or have a genetic predisposition towards these cancers. I don't know why. Okay, there we go. So everything that we do is confidential, individualized, and free. We have lots of different support programs. You don't need to know what Share It does. Let me be the Share It expert. But these are, the programs that we offer. You can order any of these things on our website, or you can just get in touch with me and I can tell you which ones sound right for you after you tell me your story. We do have lots of webinars. That's the biggest change in what Share It does since COVID began, because we've always offered support over the phone and by mail, so that didn't have to change. But we used to do about 4 webinars a year, and in 2020 alone, we did 81. So all of our webinars are kept on our website. They're recorded and kept on our website. So if you ever see one that you're interested in, but it's not a good time, go ahead and register so that you get the recording. So, Share was basically founded based around the idea of social isolation, right? We know that cancer diagnoses are isolating, even more so in a pandemic, but connecting with others can make all the difference in the world. And there was actually a study at Ohio State that found that high levels of stress led to not only depression and all these other things you can see, but faster disease progression. And one of the factors they studied in limiting the stress was seeking social support, and really focus on the seeking. It's not just getting the social support, it's seeking it. If you seek it out, you are already telling yourself, I'm worthy of this and I can advocate for myself. And that alone is so powerful. So, once you get the social support, then what, right? The sense of community can be a double-edged sword. And it's hard to remember that you get to call the shots because, it can be so overwhelming when Once people know that you have this cancer diagnosis, you know, you might be getting it from all angles. People are texting you or calling you or coming up to you and saying, oh, how are you? When you're not thinking about it and you're actually, you know, kind of having a good time, and cancer was in the back of your mind, not on the forefront. And now other people are bringing it to the forefront all the time. So just remember that you get to define your community. You get to decide who you tell. Of course, once it's out there, you don't know who they're going to tell, even if you tell them, hey, please don't tell everybody. But when those moments happen, I like to teach people about the cancer-free zone. So let's say somebody comes up to you and they say, oh, how are you doing? You know, how's treatment going? And you're not in a place where you want to talk about it. You're at the grocery, or you're at an event with your family or whatever like that. And you don't want to go there, either because of the timing or because of the person. You know, sometimes people forget we're not actually that close, so I'm not giving you this information. You can always say, oh, thank you so much for asking, but right now I'm trying to have a cancer-free afternoon, or I'm trying to have a cancer-free evening, or whatever like that. Because if you say that, any self-respecting person will, so, oh my gosh, of course, let's not talk about it. Let's talk about something else, or, you know, go back and be with your family, or, you know, they'll move out of it. If they don't, they're probably not somebody you want in your inner circle anyways. So it's okay to just say, I know, thanks, but I really don't want to talk about it right now. And some people worry that saying something like that will sound rude. I don't think you should worry about that, because it doesn't sound rude. But, you know, just know that you get to advocate for yourself in that way. Remember that it's okay to ask for help. It's really, really hard. You know, I think it's hard for all people. And, you know, I do believe that gender can be fluid. It can be a construct and all of that. But I do think that women are taught to be there for other people and not always to accept help. And so it doesn't come naturally for most of us, because I hear it from about 99.99% of Sharsheret callers. Everybody says, no, I like to give the help. I don't like to receive the help. So it's not just you, it's all of us. So just know that it is hard. And once you acknowledge it's hard, it becomes a little bit easier. And once you know it's hard for everyone, it becomes a little easier. Some people even want to practice. If you're worried about asking somebody, do it in the mirror, do it while pacing around, you know, your home. Maybe even do it with someone else that you are already getting help from. You know, say, okay, I need to ask this other person, like, let me just talk it out with you. Practicing might feel silly, but it's a really good idea. Also, remember how good you feel when you help others, right? Now it's your turn, and maybe even reframe it in your head of, it's actually, you're helping them by letting them help you. So you're doing a good deed or a mitzvah, you know, by letting them be the one to help you, because you know how good it'll make them feel. Also, you know, it's important to consider why they might not be offering. You know, a lot of times they're so worried about saying the wrong thing that they don't know how to offer. They don't know how to say it. So, you know, maybe they want to, they just don't know how. You know, the worst thing that people say, I think, and it's something that I used to say all the time before I started working at Sharsheret, and I learned my lesson, is let me know if you need something. I know we've all probably said it a million times. I've heard it said to me a million times. What does it do? It puts the onus on the person who's going through the hard time, right? To come up with what you need, to tell them, to also, you know, imagine what they're even comfortable doing, right? Because let me know if you need something. Well, what if I ask you for something and it's not what you were wanting to offer, you know? So I always tell people, you know, if they're coming to me saying, my friend was diagnosed, my family member was diagnosed, what do I do? I say, be really specific with what you can offer them, because it puts the onus on them in a really unfair way to decide, you know, what to ask you for. So, you know, that can be so annoying to hear. Let me know if you need something. Also, their worry about, you know, saying the wrong thing often just turns into silence. So, you know, a lot of people think, well, they'll let me know, or, I just don't want to say the wrong thing. So I'm going to pretend like this isn't happening. And that can be really frustrating. Another thing that can be incredibly frustrating is the type of friend or family member who just always wants to look at the bright side. And sometimes that's helpful. Some perspective is absolutely helpful at the right time and in the right dosage. So you'll learn pretty quickly who the peppy coaches in your support system are. And sometimes it is appropriate to say to them, thank you. I hear that, but right now I just can't get there in my mind. And I just want to sit here in my fear or in my anger, or in my sadness. Can you sit with me in that? And I think when you actually say that, people will surprise you. They can do it. We've been conditioned by society not to feel comfortable talking about negative things without putting the positive spin on them. So if you can kind of say that to people, I know it's hard to say, but I actually think the more we all start saying that to each other, the better prepared our society at large, and the better prepared your support system will be to really help each other during hard times. Also another thing that a lot of people do is they share horror stories. I'm sure everyone that is here today has been there where somebody, you share something and then they say, oh my gosh, well, I heard this story, or, oh, well, my, husband's brother's sister's best friend, had this happen and you wouldn't believe it was so much worse than what you have going on. And it's like, how is that helpful information? I don't want to hear these horror stories of other people, who have had worse things happen, because now I'm going to be kept up at night worrying that, oh, that's going to be my story. So, feel free to pump the brakes on those people and say, I so appreciate you sharing this, but it's actually going to give me nightmares. And you can kind of make a joke like that. And usually that will pop them out of, oh, wait, you're right. I shouldn't say that. And then unsolicited advice. I think this is the biggest one that I hear about all the time. One Sharsheret caller once said that she felt like her cancer was a purse, a new purse that everybody felt the need to comment on. And I've heard countless stories in my years at Sharsheret about this, but I actually experienced it myself before the pandemic. I got into an Uber and my Uber driver asked me what I did. And I said I was a social worker for people facing cancer. And he said, oh, well, I had cancer and I got through it. What cured me was eating bitter melon every day. And I thought, oh my gosh, this is the thing that we always talk about that people do, is giving you this, crazy unsolicited advice that you don't want, and sometimes it's something, off the wall like that, or sometimes it's, oh, you have to talk to this doctor, or, oh, well, my cousin had this type of treatment. Are you going to have that type of treatment? And it can get very specific too. So one trick I really like to teach people is the bobblehead technique. So you see these old-timey bobbleheads on the screen. Think of yourself as a bobblehead in those moments. So with this Uber driver, he tells me about bitter melon. I didn't want to get into an argument with him. I didn't want to have to convince him. I didn't want him to have to convince me. So instead, I just said, oh, wow. And I just kind of did my bobblehead thing. Oh, wow. Thank you so much. That's really interesting. I'm going to look that up. I'll share that. And if it's something, more specific, like the other examples I gave, you can say, oh, thank you. I'm going to mention that to my treatment team. I'm going to mention that to my doctor. Because when you do that, you're basically saying, yes, sure, thank you. So it's a nice thing to say. So you don't have to worry about offending anybody. But they're not going to be in your next doctor's meeting. They don't need to know what the doctor is going to say about it, or if you even actually share it with your doctor. And so it just kind of shuts it down, and they don't need to convince you, oh, well, no, you really should look into this because it really will save your life and this and that, and it'll help with this. It just shuts it down, and it can be really, really useful, in that way. So we have a closed private Facebook group amongst our Share callers, and this was posted by somebody this past summer. What's the stupidest thing someone has said to you about your cancer? I'll go first. Is that your real hair? And you can take a minute to just look at the different, when cancer looks good on you. Oh, I didn't think your hair would fall out. After my mastectomy, I was asked if my breasts would go back. What happened to mommy's hair? Chemo, what's it to you? Love that little girl. My mother said, if you took off 40 pounds, you wouldn't be in your situation. You certainly look different. And yeah, the worst was, I thought people lost weight while on chemo. And she said, I really wanted to say, and what's your excuse? I kind of wish she had. But I'm sure everybody could put things into the chat that made your head spin, that people have said to you too. So, if you have people offering help, how do you make sure that it's useful? Because, sometimes you don't want to have, more meals than your freezer can handle, so a good idea is to create a running list. So you can open up a note in your phone, or a piece of paper if you're more old school, but I like to do a note in my phone because I always have my phone with me. So if I notice, oh, we're almost out of toilet paper, or, oh, I just heard about this, date on the calendar that I'm going to need a ride, to this thing, or my kid has this thing happening. I always have my phone with me, so I can always add it to the list. So create a running list of different things you might need, from all of those examples that I just said, items you need, places you might need transportation to, things for your family, different types of things like that, whatever you might feel comfortable asking somebody for, so that when they get in touch and they say, let me know if you need something, our favorite question in the world, you can say, oh, you know what? I have a list on my phone. Are you going to Target anytime soon? And I know for me, I'm always looking for an excuse to go to Target. So, if you said I need toilet paper, paper towel, or, whatever like that, I'd probably take a trip for you, but I might not know to say, hey, I'm going to Target. Is there anything you need? So, having that running list takes some of the guesswork out of it. It makes the timing a lot, easier, because if somebody's saying, let me know if you need anything, and you can answer that right then, that's a lot easier than 2 weeks later picking up the phone and calling them or texting them and saying, hey, you had said, let me know if you need anything. Would now be an okay time? That's going to be harder for you. Might not be harder for them, but that will be harder for you. So if you have the running list, it's a really great tool. There are lots of different ways to keep people informed. People are going to be texting you and calling you, and that can be really exhausting. So, having a point person, whether it's your spouse or a friend or even an adult child of yours, who can kind of take those questions for you, and either when somebody asks you, you can say, hey, I'm so exhausted. Thank you so much for asking, but can you get in touch with so-and-so? That's one option. Or you just tell so-and-so, hey, this person reached out to me, please get back to them, and that's maybe a little more seamless. There are websites created to help you with this. Websites like Caring Bridge and Men Together have the ability for you to have a blog, which either can be filled out by you or your point person, so that you can choose what you're willing to share with your nearest and dearest. And either you email it out when there are updates, or they can check, once you give them access to it. They each have kind of different abilities. So they're both blogs, but Caring Bridge, you can also set up a meal train or a care calendar for things like transportation or walking the dog or taking the kids to school or something like that. Men Together is very cool because they have a cancer registry. So like a baby registry or a wedding registry, they cultivate a list of gifts that would be helpful, whether it's, anti-nausea pops, or, chemo beanies, things like that. They they basically have like a list. You choose what you want to add from that list onto your cancer registry. And then if somebody says, I'd love to send you a care package, or, I'd love to do something for you, you can say, oh, well, if you'd like, you can check out my cancer registry and send me something, that would be useful. That's a lot better than getting, a pair of fuzzy socks from every single person you've ever known. Like, you don't need 15 pairs of fuzzy socks, though they are really lovely. The registry kind of takes that guesswork out of it. Also, there are websites like CaringBridge, and there's like, I think even mealtrain.com, or there are lots of meal train websites. You can set it up through a website. I know lots of children's schools set up meal trains, communities like, churches and synagogues set up meal trains a lot, coworkers set up meal trains a lot. It's a really good idea to, if you have a lot of people offering meals, to actually have someone set up a meal train for you, or you can set one up yourself. Because again, you don't want your freezer filling up, faster than you can eat through it. So having the meal train, can be really helpful. And it's not just for people who are willing to drop off a meal. It can be, people who live across the country can send something by Postmates, or they can even send, an Uber Eats gift card. It really can work with whatever your support system looks like. And it's also important to remember that we know that your needs don't end when treatment ends, but your support group might not know that. So it's okay for you to remind them, hey, I know that it might look like everything's fine now, but I'm still really feeling it in this way or that way, whether it's emotionally or, we know that cancer-related fatigue lasts for, 2 years post-treatment for a lot of people. So, but the general public doesn't know that. So it's okay to share that with people. Also, it's always important to consider what kind of help is appropriate from each person in your support system, and not only what kind of help they might be, equipped to give, but also what kind of relationship do you have with them, right? So there are some acquaintances who are going to really surprise you because maybe they've been touched by cancer themselves in their family, or maybe they're just really kind people who have, always wanted to get closer with you than they are, and they might really surprise you and step up in ways. But also sometimes some people who you thought were going to really be there for you are going to disappoint you, and it can be really frustrating to see, the people who you thought were going to be there, having a hard time figuring out how to be there and maybe just not being there. So think about, what kind of support is appropriate and possible from each type of person, and it feels silly to use this example, but it just makes the most sense to me. But I liken it to how I chose my bridesmaids for my wedding. Some of them I knew were going to be there for me when I was anxious, or I was, mad at my now husband, or I was freaking out about something my mom or my mother-in-law said. They were going to be able to be there with me and help me emotionally. Other ones, knew the best fun things to plan for my, bachelorette party. And then other ones, were gonna be there to crack a joke when tensions were high, or when I was nervous right before the ceremony, or, get people up on the dance floor. So it's really similar with all of this, you're gonna want some people who can be there for you emotionally, but if certain friends who are usually there for you emotionally can't be there now, maybe there's something in their history that you don't know about, that this is really triggering for them. I often say, try not to just throw them out, but maybe move them from a high shelf to a lower shelf. Maybe they're going to be really good at just going out to lunch with you and having a distraction, and, telling you about their dating life or something silly their kids said, or, I've been tasked before. I now offer for friends going through a hard time, do you want me to send you funny memes or funny GIFs or funny videos? Do you need puppy pictures or, things like that? Sometimes people just need the distractions and the fun. So remember that that's okay. If that's all somebody's capable of, you can keep them in your support system, even if you were hoping for something else. So, the emotional help, the practical help, I've mentioned it a couple of times now, but rides to things, taking your kids to their after school program, or picking something up at Target or the grocery. And distractions and fun aren't just for you. Maybe it's for somebody else in your family. Maybe it's taking your husband out for a drink, or your partner, or your kid, needs to just get out of the house and let off some steam. When would be a good time to take them to the park? And a lot of people would love to do that for you. And it's a pretty easy, fun ask. And then, research help. I know that when I told my mom, that she could get my daughter a baby doll for her birthday, my mom researched the best type of baby doll. Okay. Most people might not do that. So if you have somebody in your life like my mom who loves to research and loves to do that for you, you can task them with certain things that you want more information about. Also, Share It has done a lot of the research. So we know a lot of the resources, whether it's a resource we provide or a resource that I know, other people like American Cancer Society or our other partners in the cancer sphere, contact me if you need some research, and maybe I've already done it for somebody else, or for our network, and I'd be happy to share that with you. So, think about today, if there's been anything, that's really resonated or sounded like issues you've had with your support system. Also think back to before your cancer diagnosis. You've been through hard times before, who helped you then? What helped you then? And can you activate those same, supports now? And, consider, how you might want to proceed a little bit differently with activating your support system and encouraging them to actually be helpful. And please connect with me and Share It. We are across all 50 states. Like I said, everything that we do is free and confidential and completely personalized to your specific needs and interests. Feel free to email me directly, or you can go through our website. If you're in California, if you go through our website, you'll be directed to me anyways. So you don't need to, like I said, become a specialist in what Share It offers. Just call me. We'll talk about what you're going through, and I'll connect you to all the right resources. And of course, follow us on Instagram at Share It Official. We post a lot about our programs and our resources and upcoming events and things like that there. And definitely join me in our breakout session at 12:15 if you want to continue the conversation, or just get in touch with me, because I know there are a lot of really great breakout sessions that you might want to hear from.
Stacy, do we have any questions in the Q&A that we should address?
There are a few. I've been copying them down for Amy for the Q&A, but
if we have some time, I can go through them now. So I do just want to say that someone asked, about Share It's area of expertise. We do focus on breast and ovarian cancer. However, if somebody, gets in touch about uterine cancer, endometrial, peritoneal cancer, we are absolutely here for you as well. We know that a lot of the emotional experience of those cancers are pretty, similar. So please don't hesitate. Our area of expertise, just because of how we were founded by somebody with breast cancer. So first we only did breast cancer. Then, because we started specializing a lot in talking about, the BRCA gene mutation, we started talking to people with ovarian cancer. So it's grown naturally. And in my 6 years at Share It, we have talked to more and more and more people with endometrial cancer and peritoneal cancer and cervical cancer. So please get in touch anytime. I also talked to somebody with laryngeal cancer last week and stomach cancer last month. So any type of cancer, you're welcome to get in touch with Share It.
Great, thanks so much. And I hope that we do get good attendance at our breakout sessions in a little bit. And I think that the conversations about cancers and the linkages between the cancers is really important too. So obviously, we don't work in a silo in gynecologic cancer. When someone comes in with symptoms, we're always trying to determine whether this is ovarian, uterine, and we also know that there are links between breast and uterine cancer, as well as breast and ovarian cancer. So I think by nature, the work has to be broad and all-encompassing.
Absolutely. We never turn anybody away. We're here for everybody, regardless of anything on your medical chart.
Thank you,
so
Amy.
much.
Thank you, Stacy. And the next part of our program is also a special treat for me, in that Some of you know that I did my fellowship training at UCLA, and I won't let you know how long I've known Paula Anastasia. But at the same time, I really wanted to link our different UC G1 oncology programs. And so I'm thrilled to be able to invite Jessica Walchonsky and Rachel Frankenthal and Paula Anastasia from the UCLA Gynecologic Oncology program to talk about survivorship. You know, we move on in our journey, we travel to different parts of the country. And so I think that this final panel before the end of the webinar section is really important as we move forward and, you know, think about thriving and surviving in the journey of gynecologic cancer care. Thanks, guys.
Thanks so much for the introduction. Let me just share our screen here.
And while she's doing that, Dr. Li Mei Chen was one of my fellows at UCLA, and I'm way older than she is, but she's a heck of a lot smarter than I am.
Okay, can everybody see it? Paula, can you see it?
Yes.
Okay, perfect. So thanks everyone for joining today, our talk on survivorship and symptom management. So as I'm Jessica, one of the GYN oncology PAs at UCLA. We also have Rachel, our other PA, and also Paula, who's our clinical nurse specialist here. So just a little overview as to what we're going to talk to everyone about today. Really, we're focusing on common effects that happen after treatment. So everybody's different. There's so many obviously lingering side effects and things that everybody can experience. But the goal today is to kind of go over the most common ones and then different treatments and ways that we can help. So our main focuses today will be on fatigue. We're going to go into healthy lifestyle and different, lifestyle changes that you can make, and also menopause. And we will have our breakout room, of course, at the end of this. So we'll go into more depth during that time and kind of answer any other questions that we don't get to during this. So just starting off, so cancer-related fatigue. So what is cancer-related fatigue? So it's a distressing, persistent feeling of just tiredness or extreme exhaustion. So this feeling can be physical, it can be emotional, it can be cognitive, and it can be all three of those. It might not just be one of those. And this feeling of exhaustion really, it's so severe that it affects your quality of life, and really kind of affects your day-to-day. So of course, there's many different causes of fatigue, and everybody's different. I would say fatigue tends to be very multifactorial. Usually it's not just one of these things that cause fatigue, but maybe 2, 3, 4 of these things. So I did list a couple of the most common causes here that we'll kind of briefly go through. So one that I'm sure all of you are familiar with is cancer-related fatigue and treatment-related fatigue. So we know that chemotherapy, we know that these maintenance drugs, we know that immunotherapy, all these different treatments can of course cause fatigue. But what a lot of us don't really mention or talk to you about is that this fatigue can persist even when you're finished treatment. So just because you finish chemotherapy or you finish radiation or whatever it may be, you might still have this lingering fatigue for months, and sometimes it can go on for even longer than a year. So that's kind of important to always mention. And then also anemia and thyroid disorders. So we look at both of those through blood work. Anemia is actually one of the most common reversible causes of fatigue. So we check anemia through a CBC on blood work. And usually with anemia, we treat it with just iron pills or blood transfusions. And thyroid disorders, we know that some drugs for cancer, so like immunotherapy, like pembrolizumab, things like that can cause thyroid abnormalities, but also just patients who have, a known history of hypothyroid or something. So if your labs tend to be off, if your numbers are off for whatever reason, that can definitely contribute to fatigue. But the good thing about both anemia and thyroid disorders is that once we, give you the blood transfusion, or once we kind of adjust your thyroid levels, the fatigue tends to drastically improve. As long as those are the main underlying factors that are causing your fatigue. And then pain is another big one that sometimes we don't always discuss. So post-operatively, after surgery, we can have a lot of pain that can lead to physical fatigue, which can also then lead to this emotional fatigue and this cognitive fatigue. So all the different kind of types of fatigue are kind of overlapping, and one can lead to the next. So pain can be post-operative. It can be, if you have a mass or tumor, maybe when you're initially diagnosed, that pain can kind of lead to fatigue. So that's another big one. And that kind of goes hand in hand with emotional distress too. So it can be depression, it can be anxiety. If your mind's kind of running a million miles a minute, that can lead to, of course, a lot of fatigue. And even just feelings of just overwhelm and sadness and things like that can lead to a lot of emotional distress and therefore decreased energy. Nutritional deficit, we see a lot with our patients and a lot in our clinic. So of course, when you're undergoing treatment, or maybe you're on a maintenance therapy, you might have nausea, you might have a lot of vomiting, maybe even a decreased appetite from whatever drugs you're on. So things like that, of course, can lead to fatigue if we're not getting all the protein and nutrients and stuff that we need. And it might just be an emotional piece of it too. So if we're feeling a little bit depressed or overwhelmed, maybe we're stress eating, maybe we're eating less. So that, of course, can contribute to this nutritional imbalance. And then sleep disturbances is a really big one. So that's anything that kind of interrupts our sleep throughout the night. So maybe we're taking too many daytime naps, so we're having a harder time sleeping at night. Or maybe we're waking up throughout the night because of pain or because of hot flashes, which we'll kind of go over all those things later as well. But that, of course, can contribute to fatigue during the day. So then briefly, what can we do about fatigue? And like I said, we're going to go over this too in the breakout rooms kind of in more detail. But really, I always recommend talk to your medical provider, talk to your medical team, because we really want to figure out what are the causes of your fatigue. So to really target what can we do to increase your energy. But some of the most common things, exercising. So it sounds kind of counterintuitive, but exercising actually does increase your energy. So, trying to do cardio throughout the week, maybe add in a little bit of strength here and there. And, that's just whatever is comfortable for you. So if you are a jogger, if you're a cyclist, that's great. If you're more of a walker and, just spend some time outside, that's okay too. So just some kind of exercise can really help with fatigue. And then exercise has also been shown to improve our appetite. So like I said, maybe you have a decreased appetite because of your treatments or the emotional side of it, but exercise can kind of help stimulate that appetite too. And then energy conservation is a big one that we don't really talk about, I don't think, enough. And that's really kind of prioritizing your tasks. So think about when in the day you have your peak energy, and that's when you should be doing these activities that take up the most of your energy. So if you wake up at 8 and 9 o'clock tends to be when you feel the most energetic and you feel really great, that's when you should be doing those kind of high level tasks. And then kind of also with this energy conservation is learn how to say no. I think we kind of touched on things like this earlier in these earlier presentations, but learn how to say no to others in the outside world. And if it's something that you don't think is important in that moment, it's okay to say no. And that, of course, takes time sometimes to get used to, but also just doing things that you love, do hobbies that are important to you and do things that you're passionate about, because that's going to really make a difference too in kind of this emotional piece of it. So if you're having any depressive feelings or anxious thoughts, doing hobbies that really just make you happy is important. And then self-monitoring your fatigue levels. So if there's any change, of course, let your providers know, let your team know. And then improving your sleep hygiene. So I always recommend kind of avoiding screens, maybe 60 to 90 minutes before you go to bed. So instead of going on your phone or instead of watching TV, maybe read a book or do some gentle yoga, meditation, things like that can really kind of help improve our sleep hygiene. And like I mentioned, definitely bring up fatigue to your healthcare providers. So there's many different referrals that we can make, and we kind of touched on these different specialists earlier in the day too, but Palliative care is really, really good at symptom management. So they're really great people to talk to. You know, maybe you became deconditioned during treatment, or you're deconditioned because of surgery. So we can put in referrals to physical therapy and occupational therapy. Nutritionists tend to be really great too, of course, if there's kind of that dietary component to it as well. And there's other methods too. And like I said, we'll kind of go over it more, but acupuncture, yoga, meditation, we don't have great studies and research showing that these things work. But I would say what I've seen in practice and just things that I hear from my patients, these things can really, really help kind of stimulate your energy and decrease the fatigue. So really it tends to be kind of a combination of a lot of different things, and really just figuring out what that underlying cause or causes is. So that's kind of the brief thing on fatigue. And like I said, we'll talk more in the breakout room, but now I'm going to turn it over to Paula, who's going to talk about kind of lifestyle changes.
Thank you so much, Jessica. I think you covered my talk, so I'm just going to turn it over to Rachel. No, I'm going to be very quick because I want to keep us on time so that we can all enjoy the breakout session. But it's interesting. Earlier today, they were talking about obesity, which is huge. And I think that sometimes we don't talk about patients that are undernourished, as you mentioned, Jessica. And that's a whole different mindset. I'm focusing more on patients that need to keep their healthy body weight. And since we're talking about GYN oncology, endometrial cancer, as was discussed in the morning session, there's a definite obesity problem in the country, more so in the Midwest than in California, of course. But endometrial cancer is highly, highly curable with early detection, which most patients are diagnosed in the early stages. And I hope we have a lot of survivors on this. Unfortunately, women will be cured of their endometrial cancer, but they will die of heart disease because they are overweight. And we clinicians did nothing to talk to them about a healthy body weight, because God forbid it would be fat shaming. We're not fat shaming. We want you to live healthy. And being overweight is okay. Many of us are, but we don't want somebody to be obese. And so one of the things that we talk about is, nutrition. And as Amy had said earlier, people provide unsolicited information, and so many people say, oh, you can't eat sugar, it's going to make your cancer grow. Sugar will not make your cancer grow, and it will not make it go away, okay? But we know everything in moderation is fine. Obviously, more plant-based fruits and vegetables are better. But if somebody wants to splurge and have a dessert, or you're going to have some French fries, or a glass of alcohol, that's perfectly okay. But we do know that if you eat sugar-rich foods and you gain weight and are fat, you are going to increase other risks. Now, we know that women especially, and I'm going to focus on my tummy, if you have midsection fat, that is where extra estrogen cells are. So that puts you at risk for endometrial cancer. So women that are overweight that don't have cancer, that's why we want to maintain a healthy lifestyle and body weight proportionally. It's okay to be a little overweight, a little fleshy, but obesity is not good. We also know that estrogen can increase the risk for breast cancer. So again, if you eat sugar, it's not going to make your current cancer grow, but we know lifestyle changes. We know it can cause diabetes, hypertension, cardiac problems. So that's why we really want to stress a healthier diet choice. My bestest friend in the whole world has always been obese. She lost 100 pounds just by counting calories. To this day, she has kept it off for about 5 years. She won't do a lick of exercise, but it's all calories in, calories out. Now, I'm a huge proponent of exercise. And there's, and here we are saying, oh, you got to exercise. Well, my husband hates to exercise. It's like, he's not going to do it, but he knows it's good for his health. So he will just walk around the house when he has the football game on. Okay. So little things like that, you move, and you don't have to be a cyclist or a jogger, but you need to do something. I always ask my patients, do you watch TV? And most people do. And I said, okay, during a commercial, I want you to just march in place 5 or 10 minutes. So it's not drastic changes in your life, but little things that are going to help and keep you healthier and stronger. And I think about as we get older, regardless of cancer, bone health and osteoporosis and that sort of thing. So we want to protect our bones. So another thing we talk about is weightlifting. Well, not everybody's going to the gym and not everybody has weights at their home. So I always tell my patients, use little water bottles or soup cans or something so that you are moving, okay? And you can do this during a commercial break. You can do it if you have earbuds and you're talking to somebody that talks too much. You can be jogging in place while you're talking to a friend or loved one. So there's things that you can do that aren't going to be like drastic changes in your life, but they can really make a difference for improvement of your life. So again, the exercise, I'm the oldest one on this, and you probably don't remember Jack LaLanne, but when I was a little girl, he was the first guy doing exercises on TV. And he used to sit on the couch and say, okay, for those of you that, can't walk because you have bone problems or knee problems, you can sit on the couch and you can do stretches and you can try to, do sit-ups. So you can always do something. So anyway, that's my little spiel there. I'm going to move on to talk about emotional health, which Jessica did very well, but it's interesting. So, you got through treatment and it's kind of like, okay, get on with your life. We'll see you in 3 months. And you're like, what? And so it's really interesting because most patients, this is not uncommon, most patients spend their time during treatment, surgery, chemo, plus or minus radiation, just fight, because they want to survive. And then when it's all over, it's like, whoa, it's just processing. It's like, what have I been through? So there may be some delayed anxiety, depression, sadness. And, people are like, what are you upset about? You're in survivor mode, you're done with treatment. But it's a huge process and it is so much more common than we realize. So I think addressing that, I think it's important for caregivers to know that. I think it's important for us as professionals to be referring our patients at the very beginning to palliative care. And I love the speaker this morning who was talking about palliative care. Palliative care is symptom management, and emotional health is just as important as physical health. So that needs to be addressed all through it. Many patients have told me it's like a post-traumatic stress syndrome where all of a sudden, I don't know how to move forward. It's like I look in the mirror and it's not me. I don't have any hair. I don't have any eyelashes. And I have issues maybe financially, and I may have to go back to work. And Rachel's going to talk about menopause and sexual health. My partner was so supportive and loving, and I felt guilty that I had no libido or had no interest in sex, and I still don't. So all of those things with relationships, and what about those that aren't in a relationship? How do I begin dating or finding a partner? When do I tell them that I had cancer? There's just so many things that are normal, but they're complex, and we need to be treating the whole person and also helping with referrals for social workers, therapists, other patients who are going through it, support groups. And again, some patients may like one avenue over another, but I think to recognize that is so important. And then the chemo brain, which can last 6 months to a year, where it's just like, oh my gosh, I'm forgetful. And then you think you have, dementia. And I think Amy did a great job giving helpful hints of writing down notes. Dr. Gupta on CNN, he had a family member with Alzheimer's, and so he wrote a book. And I thought it was really helpful because one of the things he talked about is training your brain, even for cognitive changes, which will get better, is to learn a new task. Like for instance, if you brush your teeth with your right hand, use your left hand. So do something differently than you normally do. So anyway, we have the breakout group. We can go into more of this. I want to turn this over to Rachel, who's going to have a very stimulating conversation for you as well. Thank you.
Thanks, Paula. Thanks, Jessica. We're so happy to be here with you all today. We wanted to address menopause because so many patients are either going through menopause when they're diagnosed, and treatments can exacerbate those symptoms. And sometimes patients get put into menopause because of their treatment. And, menopause can cause so many symptoms and side effects. So we really wanted to take a moment to focus on this. The definition of menopause is 1 year without a period. So 1 year without menstrual bleeding. And the lack of periods and the loss of ovarian function is what leads to a decrease in the hormone estrogen, which is produced in the ovaries. And that's what causes all of these symptoms. The average age of natural menopause in this country is 52. However, as I just mentioned, and as many of you know, that some gynecologic cancer patients will enter premature or induced menopause due to surgical removal of the ovaries, chemotherapy, and or radiation. And so chemotherapy and radiation can permanently damage ovaries, and sometimes ovarian function will come back to some degree, and sometimes it won't. And the process of going through menopause can be very different when a woman or person goes through it naturally, which can take years and years and years, to someone who goes through menopause like this, right? Their ovaries are removed, they come out of surgery, they're in menopause. So that exquisite, drastic shift in hormones and the experience of that, especially for young people, can be incredibly disruptive and very overwhelming. And so we want to talk about this. And you certainly want to bring it up to your providers if you're struggling. And so regardless of how a person goes through menopause, the symptoms can be the same. All right, so some signs and symptoms of menopause. I'm sure many of you are familiar with them. Hot flashes or hot flushes. So a hot flush is when you feel really warm, your face gets flushed, but you might not develop full sweats and chills. Either way, they're symptoms of the shift in hormone. Mood changes, anxiety or depression, irritability, and just not feeling like yourself. I didn't put fatigue in here, but fatigue is a big one. Sleep changes, so just changes to how your sleep pattern is, or insomnia, just difficulty sleeping in general, very common. Vaginal dryness, painful intercourse, decreased libido or no libido at all. Brain fog, which is similar to brain fog you can get from chemotherapy. So sometimes it's hard to tease apart what's menopause, what's chemo. But if you're in that age range, or you know that you were put into menopause from treatment, it can be both, which can just exacerbate any of these symptoms. Joint pains, muscle aches, weight gain, and just the change in weight distribution. A lot of times in menopause, women will develop more fat in their midsection, their thighs, in their butt area. So your body can just shift, and that can be hard too, right? Because your body feels so different after treatment. And then you go through menopause too, and that changes the way your body looks and feels. So it's just a lot. It's a lot to go through. Dryness in general, we talk dry vagina, dry eyes, skin, hair, and you can also have hair thinning or hair loss. So I know I mentioned just a ton of symptoms, and it can be like very overwhelming, very scary. Nobody wants to go through menopause, no one wants to talk about it. I feel like in our culture, we don't do a great job of addressing this, but I really want to address, and we're going to do this in the breakout room, that you don't have to suffer through menopause. And I think that we really do a disservice to people with ovaries in this country, because our culture, TV, film laughs about it, jokes about it, hot flashes, mood changes. And I think a lot of women assume that just because these symptoms are really common, that it's okay to suffer. It's not okay, right? Just because it's common doesn't make it okay. So if you are suffering, you have to talk to someone. And if maybe your provider isn't super helpful, you find somebody else who's going to listen, because you can feel better. And similar to the way that we want to think about survivorship, we want to help our patients return to wellness. We want them to find confidence and empowerment in everything that they've been through. We feel the same way about menopause, right? It's a transition that everyone with ovaries is going to go through. It's incredibly common. And we want to celebrate that transition and that entry into the next phase of life. And so be kind to yourself, be patient with yourself, don't judge yourself, and don't compare yourself to anyone else. Everyone's going to have a different experience of this. And we're going to discuss lots of interventions on how to address these symptoms, but just know that the strategies for addressing menopause are huge. And, it spans from everything from acupuncture to supplements to support your body, your moods, your health, yoga, therapy, and medications as well. Some survivors are also a candidate for hormone replacement. So please ask your provider if hormone replacement is safe and appropriate for you. I think that's it for this portion. Does anybody, I don't have any questions. I'm looking in the chat. I don't see anything, but you can always reach out to us if you would like, or come to our breakout session, which is where we're really going to get into how to address these symptoms.
Thank you very much. I'm really glad to have you here. And as some of you don't know, but I think that the team from UCLA was talking about putting together an entire symposium on this, and I know they could talk for an entire symposium on this topic. So we're hoping to have a little bit more time for some one-on-one conversation in the breakout rooms. And that's where we're going to go to next. I wanted to thank everybody for participating. The attendees, our friend circle, our sponsors, and our speakers. This looks like little footballs that everybody's carrying there, Kevin. But everybody who's been into the symposium has been in touch with Kevin. So let's all do applause things if we can for Kevin Anderson, who is our division analyst, who has been invaluable in terms of organizing the friend circle, in terms of keeping us on schedule, in terms of sending out all the communications. And so I wanted to thank Kevin, and I wanted to thank our speakers. I wanted to thank our sponsors. I learned a lot, and I think that part of the purpose of this symposium is education, but also awareness, and to keep the conversation going. And I hope we've built a community for everyone's journey, to be able to find people to talk to in this communication and network. I wanted to let you all know that we're going to be sending out a feedback survey. So if there's things that you think that we should be including in next year's symposium, please let us know. We do try to build a community. So, being able to reach out to communities that aren't here is important as well. So helping us think about that is important. Myriad and GSK were our sponsors this year. I put in a little hashtag earlier. If you do post to social media, UCSF Gynonc 2022. The website will have information, and in a few days we'll post the videos of the speakers and the different sessions, and you should also be receiving a virtual gift basket. So the final word for the symposium, I always give to our friends circle, and so representing them today is Sarah Velvey. Sarah.
Thank you, Dr. Chen. And let's not forget to give Dr. Chen a big hand in this as well. She not only is sort of the driving force in the creation and continuation of the symposium for 10 years now, she's also the director of the Gynonc program at UCSF. So she's seeing patients each and every day, as well as staying on top of everything that's new with the gynecologic cancers. So she is a woman of many hats and works incredibly hard for all of her, I'm going to say constituents, that may not be the right word, but patients and colleagues and everything. So major kudos to her as well. So my name is Sarah Velvey. I am a member of we call it the UCSF Friends Circle. And even though UCSF is attached to our name, we are a group of patients, mostly, from many different medical institutions. So we're a group of people who get together for peer-to-peer support. We also are lucky enough to have a hand in organizing the symposium, and we can go ahead and create events of our own as well. We haven't done it since COVID, or creating an event. What we have done since COVID is to put our peer-to-peer support group online on Zoom. And it's actually worked really wonderfully because we have people from all over, mostly the Western United States, come together every 3 weeks for peer-to-peer support. And we find it, people really appreciate it. We work in small groups, and you get to drill down into people's questions, concerns, and success stories on a very personal and detailed level. So we are a place of connection, support, community. You can go ahead, as I said, we're open to patients from any institution at any place in their cancer experience. I no longer use that other word that you can use because my experience is long, and I don't know. Anyways. Any gynecologic disease or all the gynecologic diseases are represented in our group. So it's open to anyone with a gynecologic disease. We also will be staffing some of the breakout groups today. So please, see us there as well. I think that's what I have to say. Thank you, Dr. Chen, for letting me have the last word. It's very sweet of you. And I hope to see many of you in the breakout groups. They're really wonderful, and you will definitely get to drill down into some of these topics a little bit more in depth. Thanks so much. Take care.
Kevin, do you have our slide with all the breakout sessions one last time? We can put it up as people transition, and we're going to meet at 12:15, everybody.
Thank you all for attending. I'm going to go ahead and close the session and you guys can join the breakout rooms. Thank you, guys.